But there is no referral because I cannot see.
All right. So you can hear me now?
Yes, we can.
All right, first, good afternoon, everyone. This is Dr. Koussayer. I'm in Dubai now. I have the pleasure and honor to work with Dr. Oye during our fellowship. And he's very, very sincere friend. Thank you, Oye, for inviting me for this nice meeting. I'm going to speak about, I think, important topic is that how you deal with acute aortic syndrome during pregnancy, because you may, see that during your practice. Next.
Okay.
So acute aortic syndrome, including really 4 syndromes, is acute aortic dissection, intramural hematoma, symptomatic peptic ulcer disease, PAU, and traumatic aortic injury. Next. I think I prefer if I have the control, please. Usually pregnancy increase the risk from 0 to 12 per 100 to the 1.45, which increase about more than 10 times. So pregnancy itself increases the incidence of acute aortic syndrome. And mortality can go up to 30% for the mother and 50% for the fetus. So what are the risk factors for acute aortic syndrome during pregnancy? The most risk factor is heritable arteriopathy, like Marfan syndrome, Whyte syndrome, and the Whyte syndrome usually is high risk for dissection during pregnancy, especially if you have a mutation, gene mutation, which is TGFR1 and R2. The other arteriopathy is vascular Ehlers-Danlos syndrome and Turner syndrome. And the other pathology or risk factor for aortic dissection is aortic dilatation, and hypertension, and family history of aortic dissection or sudden death. So what the pathophysiology? Usually we see a significant hemodynamic and hormonal change during pregnancy, especially during the third trimester and peripartum period. So all these hemodynamic and hormonal changes cause increased blood volume, cardiac output, and sympathetic activity. And this combination of hemodynamic changes and the aortic and the connective tissue disease lead to the aortic wall vulnerability and dissection, especially if woman has a pre-existing aortic dilatation, secondary to the genetic arteriopathy. So what the presenting symptom? Usually as common symptom, usually present with a sudden severe chest pain, back pain, and abdominal pain, but sometimes it may accompany by syncope, neurological deficit, pulse deficit, or sign of heart failure. The main problem is when patient have non-syndromatic thoracic aortic connective tissue disease, because this one you don't have a manifestation of connective tissue disease like a Marfan or Ehlers-Danlos syndrome. So the first presentation could be an aortic dissection during pregnancy, and we see that in about 20% during pregnancy. So what the preferred images during pregnancy? If you're looking for the aortic root, the best way to do TEE. If you're looking for the aortic arch descending aorta, the best way to do MRI, but without gadolinium. CT scan is, of course, risky during pregnancy, but sometimes we do it if MRI and TA are unavailable or contraindicated, or we have to do it for life-saving intervention, then we just have to bite a bullet and get CT angiogram. What are the complications associated with this modality? If you use a contrast ionized contrast agent with CAT scan, this can lead to the transient neonatal thyroid dysfunction. Of course, using radiation with a CAT scan can lead to the miscarriage, birth defect, or intellectual disability if exposure happens, especially during the first trimester of pregnancy. If you use gadolinium with an MRI, this can increase the risk of stillbirth, neonatal death, and inflammatory condition. So if you have to do MRI, it's very important to tell them without gadolinium. Next. So let's talk about what the most common dissection. The worst one, we get type A dissection in Marfan syndrome. And usually it relates to the pre-pregnancy aortic root diameters. So if patient has a Marfan syndrome and she wants to get pregnant, we look at the aortic root. If the aortic root less than 40 millimeter, then the really risk of dissection during pregnancy is very low, less than 1%. We can tell the patient to go and get pregnant. We have no issue. But if the pre-pregnancy aortic root diameter more than 45, then the risk of dissection is very high. We advise her to avoid pregnancy and to proceed with the preemptive repair of the ascending aorta. If the size between 40 to 45 millimeter before pregnancy really is no clear recommendation, then we have to do a shared decision making, how important the pregnancy for her, how many kids she has, and then we have to make a decision. So 40 to 45 is a gray area. Next. What about type B dissection? Usually also associated with a connective tissue disease, about 20 to 40%. It may happen without pre-existing aortic dilatation, and also it may occur after delivery in postpartum period within 3 months, but sometimes we can see it after to 1 year. The patients who are at high risk for aortic dissection type B, we see sometimes slight increase in the risk of aortic dissection during pregnancy, even in the postpartum period. Next. So what are surgery for aortic dissection? What's the recommendation? The risk of dissection should be discussed in patient if she has a marked aortic dilatation or rapid expansion more than 3 millimeter per year. So this kind of patient we have to discuss before pregnancy risk of dissection and should go proceed with the pregnancy or not. If high maternal mortality is expected, then the mother is more important. So early pregnancy termination, it may be recommended. Prophylactic surgery during pregnancy should be carefully considered. If we decide like is the aorta get dilated, then we decide to do prophylactic surgery during surgery, then you have to take on your consideration both the fetal and the maternal risk, and then you decide, should I do it through pregnancy or just keep watching the patient until we get through the pregnancy and then we do a surgery. So if patient start getting dilatation of the aorta during pregnancy, then decision should be considered, taking into consideration the fetal and maternal risk. But what if patient get type A dissection? Now, the one before, please. If the patient got type A dissection, if this happened the first and second trimester, then we can go proceed with the repair and we can keep pregnancy, but you have to monitor very carefully the fetus. The best way, if this happened during the second trimester, this is the safest way for the fetus. But first and second trimester, we can proceed with surgery, but you have to be very careful, monitor the fetus. If it happened acute type dissection in the third trimester, then we just go, because baby is already mature, we just proceed with the emergency section, and then we proceed with the repair of aortic ascending aorta. Next. If patient came with a type B dissection during pregnancy, then we deal it like anyone. We treat it medically. Unless malperfusion or ruptures happen, then we have to do endovascular or surgical repair. And of course, we have to take in consideration the life of the fetus and the maternal. If we see a progressive aortic dilatation during pregnancy, then we have to think about prophylactic aortic surgery. And again, decision should be taken individualized, depending on the importance of the pregnancy for the mother and her life and other risk factors. If the gestational age more than 28, this is the best time. This is where you have the highest survival. So anything, if you can postpone it until the gestational age become 28, you get the best survival for both the fetus and the mothers. Next. So how is the outcome? The outcome depends really on management strategy, type of dissection, A or B, gestational age, and underlying condition like Marfan or Ehlers-Danlos syndrome, what type of connective tissue we are dealing with. But in general, maternal survival at 5 to 6 years of the dissection is about 65 to 70, and the fetal survival is about 50 to 68%. So what the guidelines tell us about this condition? If you look at the latest guideline 2024, which is the EACTS and STS guideline for diagnosis and treatment of acute and chronic syndrome of the aortic organ. So what the guidelines said next? Regarding the delivery, they said if patient has a history of aortic dissection, then C-section is recommended. You cannot let the patient go through normal delivery. If the aortic root less than 40 millimeter, then patient can have a vaginal delivery if she wants. If the aortic root more than 45, then C-section should be considered, and don't let the patient go through normal delivery. And at the same time, she has to undergo an urgent aortic root repair. Next. About surgery before pregnancy, if again the aortic root more than 45, then we recommend to do a surgery and repair the aortic root before she proceeds with the surgery. If the aortic root is between 40 to 45 millimeter, then aortic repair before pregnancy may be considered in the present if the patient has risk factor for aortic dissection like family history or rapid growth of the ascending aorta more than 3 millimeter per year. Next. What about surgery during pregnancy? Urgent repair is it's important if patient get acute type A dissection during the first 2 trimester, you can keep the pregnancy. But if patient get type A dissection during the 3rd trimester, they will recommend to go an urgent C-section followed with aortic surgery. If patient came with acute type B dissection, then optimal medical treatment is recommended during pregnancy unless complication happen like malperfusions. And recommendation is 1C. Thank you very much for your attention. Any questions?
I've got a question, Dr. Koussayer.
Any question for me?
Yeah. I want to ask,
yes,
what makes gadolinium contrast particularly risky during pregnancy when compared to iodinated contrast?
No, iodine is because gadolinium, as you said here, you see, if you go back to the slide, it found it can cause still birth and deformity for the babies, you know. Yeah, do you see here? Gadolinium can cause stillbirth, neonatal death, and inflammatory condition. This is being showed. So anytime you need to do an MRI during pregnancy, should be done without gadolinium. Ionized is not very problem because it just cause transit neonatal thyroid dysfunction. So I think gadolinium is worse. But the problem with the CT scan is not the contrast, it's the radiation, which is very risky, especially in the first trimester. If you pass the first trimester, it's not our first choice, but you have to do it for life-saving condition or something like that, then you have to do it, you know, as far you are past the first trimester. If your first trimester is a risk, high risk of, you know, fatal deformity, and then you have to discuss with the mother if she want to keep the baby or not. Any other question?
Go ahead.
Samir.
Yes.
Hi, how are you? Hey, how you doing?
Hey, oh yeah, nice to hear your voice.
Samir, good to hear from you.
Yeah.
Thank you. Thanks for the thank you. Thanks for the interesting talk. I appreciate it. Yeah. Yeah.
Thank you, for inviting me. I really enjoy it, you know. Hopefully next time we'll be in person.
Yeah. Yeah, we'll chat later. Thank you. Okay.
Thank you. Take care, guys. Bye-bye.
Hey, how you doing? That's it. Yeah, no.
Bluetooth connected.
What's the next stop? The next one.
Who's the next speaker? Ask Brian. You can say something.
This is our keynote speaker. Yeah, that's Bass. That's our keynote speaker.
Hey, Dr. Das.
Yes, good morning.
Good morning.
Dr. Oy.
Just give me a second, Dr. Das. I'm trying to get in touch with Dr. Oye.
Okay, thank you.
Yeah.
In the UK, I came from Nigeria, and Dr. Diedrich, our trainer, the only one. So today's going to talk about. So in Nigeria, he's a good guy. So today's going to. He's a good guy. So today's going to. He's a good guy. Oh my God. I guess. Oh my God. Oh.
Hey, Dr. Das.
Hi, good morning.
Good. I think you might be able to start your presentation.
Okay, tell me, hello?
Yes, I can hear you.
Can I request you, can you please switch off the microphone for the delegates or the audience? Because there's a lot of echoing, and that's because of these microphones are still active.
All right, I'll do that. Thank you.
Okay, can you see my slide?
Yes, we can.
Okay, so I can start now.
Yes, please.
Okay, thank you.
Yeah.
So thank you for this invitation to Dr. Whyte and Dr. Ibrahim and the organization committee for this meeting. Now, I thought very hard and I thought it is timely that we discuss this issue of amputation and the devastating effect it has got in the life of our patient, the family, and the community, society, and the economic consequence of this devastating consequence of amputation. Now, amputation does not need to be condemned. Sometimes it also saves life. But unfortunately, not like this picture. This is a Scottish surgeon who performed an amputation in 25 seconds, and the mortality rate was 300%. You might be thinking how the mortality rate could be 300%. The surgeon operated in 25 seconds, harming the patient's finger, the attendant's finger, and also the family at that time were allowed to attend the operating, and one of the family member also got injured. And ultimately, they all developed sepsis and died subsequently. So this is not the situation, however, today. We have got conquered the sepsis by aseptic procedures. We have got care pathway put in place so that everybody sticks to the guidelines of performing an amputation. And the results are much better. People can be put into prosthesis and into rehabilitation, and they can lead a normal life thereafter. Now, peripheral vascular disease is the commonest cause of amputation, non-traumatic cause. And almost 50 to 70% of the patients who have got peripheral vascular disease is also associated with diabetes. And most patients are above the age of 60 and male. And in UK and most of the European country, the peripheral vascular disease affects mostly elderly group of population. By the age you reach around 80, almost 8 to 10% of the population have got peripheral vascular disease. So there is a significant problem with peripheral vascular disease. And to that also, what we need to recognize that the amputations also rising, absolute amputations, because there is a growth of population, the number of diabetes also rising in the community, and people are aging, living longer. As a result, the disease is taking its toll in amputation. And apart from that, particularly the elderly group of population, they have a history of frequent fall and injure themselves, and that also leads to amputation, bed sores leading amputation, and so on. But one of the most striking feature of these statistics is that age-adjusted rates of amputations are falling due to better prevention, recognition, and aftercare. But if you look at the presentation of patients with peripheral vascular disease, there is a higher than global average due to late presentation and limited vascular care. And I'll come back to this issue later, little in my later part of my talk, and why it is so. And we know that diabetes, peripheral vascular disease, trauma, infections are all the common causes of amputation. In some part of the world, particularly those who are developing or less developed countries, they have got limited access for screening, limited access to vascular surgery. And not only that, we have also got very sparse national data. There is no robust data which actually identifies the magnitude of the problem with peripheral vascular disease and amputation, particularly in sub-Saharan Africa. And we hope that this regional study in Africa will address this issue, and we'll have a better knowledge of the prevailing picture regarding peripheral vascular disease and amputation. The unfortunate aspect of this story is this, that most of the amputation takes place even in younger adults in the sub-Saharan Africa compared to the global trend. And this is a very serious issue. Now, if you see the difference between the high-income countries and sub-Saharan Africa, why there is a great deal of difference with regard to the amputation rate, is there is no routine vascular check in the sub-Saharan Africa. This is not available. Amputation remains the first line of treatment in sub-Saharan Africa if somebody presents with peripheral vascular disease or tissue loss. And there is limited access to funding for prosthetic rehabilitation. So therefore, it remains paramount that how can we save this patient's leg by performing vascular intervention at the appropriate time. And as I said earlier, that there is sparse fragmented data available from sub-Saharan Africa and less developed countries. So we don't know exactly the magnitude of the problem in this area. Now, if you look at the RAM study, which is designed to address the epidemiological data that can be derived for over 10 sub-African countries, and which is a multi-center data collection, and hopefully that will provide us all the information that we need, what is the existence of the problem in the sub-Saharan Africa. Now, if you look at the global population suffering from peripheral vascular disease is over 200 million people worldwide. And in this population, there are thousands of preventable amputations that occur each year. So it's like, if you compare this with the COVID pandemic, it's like a pandemic with significant consequence of amputations like death from the COVID pandemic. And therefore, one would think that we should be thinking about a miracle vaccine that will cure the disease and prevent amputations. And the prevent amputation is largely largely related to the delay in diagnosis, and that leads into the irreversible damage to the tissues, and subsequently the end result is the amputation. And this is not the fate of the patient, but this is actually the failure of the system that we haven't been able to provide the basic necessity for early diagnosis, screening, investigation, and the treatment that is necessary to salvage these limbs. We have got all the information that are necessary. We have got facilities for screening. We have got diagnostic procedures available. And we have got treatment like endovascular therapy. And there is also a proven care model that can be put into place to prevent amputation. So we need to deploy it. We don't have to innovate anything new. We need to deploy all these measures so that we are able to save these limbs. So therefore, who should act to implement this strategy? It is us as the clinicians who should put in place earlier screening methods, refer to the right expert at the earliest stage, and we need a collaborative care by multidisciplinary team who are involved in the overall care of the patient, so-called the holistic care of this patient. We should enable funding of the pathway of care for this patient in the same way as we fund for the heart disease, for stroke prevention, and cancer care. We should ask the policymaker to invest in prevention, not just for making facilities for prosthetics. And we have to train our younger generation and also some of the younger consultants to recognize the urgency of treatment in these patients so that amputation can be prevented. And also, importantly, that we have to raise the awareness, not only amongst our clinicians, but also with our patients, that in such an event when they develop an ulcer or rest pain and so on, they present early and seek clinician opinion as early as possible for better care. Now, the other thing which is important and why the sub-Saharan African countries are suffering the most, there is inequity of services available in this area because of lack of resources and various other things, and that are necessary. The most important thing remains awareness and the rapid diagnosis and treatment. So what can we do to help this? So that is where the vaccine terminology has been derived to address these issues. So we should do the screening, preferably using ankle brachial pressure index measurement, which is very simple, can be done at bedside, and we can pick up the large volume of the patients with peripheral vascular disease. Awareness, raising the awareness of the patient and the public and the clinicians that peripheral vascular disease remains one of the causes for pain in the limbs, ulceration, and so on. Care pathways must be developed as it is currently available in the European or American countries, and this must be implemented carefully. And there should be equitable access, as I have been claiming about this, that everybody should have that should be the human right for every patient. They should have access to the diagnostic armamentarium, interventions, and subsequent follow-up. We don't need any further innovation. We have already advanced quite a lot with regard to artificial intelligence diagnostics, wearable techniques, and all these things can be employed for early detection of the disease. And the treatment should be patient-centered. All these treatments should not be fragmented, distributed in several different hospitals across the country, but they should be concentrated in one place so that the patient can receive the benefit of the entire holistic care that are necessary to save the limb. So what has happened over the years? A lot of research have been developed, particularly the risk factor identification and prevention in patients with cardiovascular disease. And we have been very successful in doing so. Rate of hypertension has gone down. Rate of serious acute cardiac illness has gone down because of the addressing risk factors operated in all these patients. We have also worked on the development of various antiplatelets, antithrombotics, recognizing the important contribution they make in preventing thrombosis in these arteries and leading on to thrombosis, and that can be prevented and prevent amputation in these patients. There are a lot of landmark that have been done over the years, and that has established the role of antiplatelet, role of antithrombotic agents as a singular method or double method. And together with that, we have also learned that instead of surgery, we should be thinking about endovascular treatment to treat these problems fast. We have also introduced structured exercise program to treat claudication where surgical therapy is not possible. Dual pathway therapy, I will discuss about this later on in my slides. And there are new medicines which can also cause angiogenesis of the ischemic tissue by regenerative trials. And also we should be doing geriatric old people screening in order to identify chronic limb-threatening ischemia at an earlier stage in this patient. And finally, multi-specialty care models, which provides diagnosis and investigations and treatment, and this is important in this treatment modality. So now I'm going to present serially the results of the landmark trials that have shown the benefit of antiplatelet trial. This is an antiplatelet trialist collaboration study in the 90s, which suggested that platelet or any other antiplatelet does reduce the risk of cardiovascular illness and morbidity and saves amputation and reduces the risk of cardiovascular morbidity. This is another study, which is called the TAPRI trial, that established the role of clopidogrel in reducing cardiovascular morbidity and mortality, and this was performed in the 1990s. And since then, even we learned the combination of dual antiplatelets, aspirin and clopidogrel, also improves the results much further. And this is another important trial, which was only conducted in the 2015, the combination of antithrombotic agent, rivaroxaban, and the antiplatelet agent, clopidogrel. When you combine them, the relative risk and absolute risk of cumulative incidence of cardiovascular illness reduces quite significantly. So therefore, we learned from this study that we should be, where it is not contraindicated, we should be prescribing dual antiplatelet and as well as the antithrombotic agents to reduce the incidence. Thereafter, we also heard from the COMPASS study where they compared aspirin with rivaroxaban and rivaroxaban plus aspirin compared with rivaroxaban alone. And they found that when you combine aspirin with rivaroxaban, the results are much better. If you follow them long-term, then the cardiovascular morbidity is much better in this situation. And then comes the various studies that have been done in the development of various devices. And this was necessary largely because although angioplasty stenting were successful, but the results were not long-lasting and the long-term patency rate of the blood vessels were not satisfactory. And this is largely due to the bulk of the calcium deposit within the atherosclerotic plaque was not possible to remove. And here that led on to the various trials, to start with one of the atherectomy device that started. And then subsequently, we had the orbital atherectomy devices, we had the rotational atherectomy devices, and laterally we added to the armamentarium shockwave lithotripsy. All these different methods have allowed us to debulk the calcium and atheroma load within the arteries, and they have been very successful in the femoropopliteal vessels and even the iliac vessels. And together with that, we can consider doing stenting in these patients, and that will improve the long-term prognosis of treatment in these patients. Then comes the magic treatment with intravascular lithotripsy. This is a meta-analysis of several studies, individual studies, and that shows there is a good success rate of using lithotripsy in debulking the calcium load in these vessels, and that also improves the result. Now, this is again the comparison between lithotripsy and rotational atherectomy, and you will see that lithotripsy achieves better result compared to the rotational atherectomy in most cases, but otherwise both the procedures have got similar results. This is an example of where both rotational atherectomy and lithotripsy have been combined to reduce the bulk of the calcium as in this patient. And subsequently, the vessel has been stabilized with the deployment of a test stent. And this certainly improves the long-term success rate of this procedure. This is another scenario where a patient developed with gangrene of the big toe, and he had series of procedures, including shockwave, and then ultimately all the calcium and stenosis were treated very nicely, and subsequently this is the end result following the treatment, and he has good flow to the distal foot with healing of the gangrenous of the big toe. So such is the result of the additional treatment for this procedure that we can achieve prevention of amputation. This is another result of the orbital atherectomy. And as you can see, depending upon according to the Rutherford classification, depending upon the amount of stenosis, the results also improves. The lower the stenosis, the improvement is much better compared to if it is higher the stenosis as in these groups. This is another very interesting study where they use the scaffold, where the stent scaffold disappears after about 3 months of stay, having done its role in maintaining the lumen of the artery. And here they are also treated with a drug-eluting resolvable scaffold. And if you follow these patients after treatment at the end of 3 years, there is a better result in the scaffold group compared to the without scaffold and the drug-eluting stent, simple angioplasty. And if you look at this is the efficiency rate. If you look at the safety rate, there was no difference between the two groups of treatment procedures. And this is again restenosis rate also in the scaffold with the drug-eluting stent. The results are much better here compared to the angioplasty alone. This is further study that was done comparing the vascular bypass, which used to be the norm in the past, comparing with the endovascular treatment. And it all showed that amputation rate is much less in the endovascular procedure strategy first compared to the vascular bypass. Similarly, the morbidity rate, overall survival rate is much better with endovascular treatment compared to the angioplasty alone. Surgical surgery treatment. And furthermore, after all these successful procedures, endovascular and open procedure, as well as the addition of antiplatelet and antithrombotic treatment, there are other new treatments in the horizon, particularly the role of stem cells is causing angiogenesis and improving the blood supply, blood flow. A lot of studies have been done in this regard. And then the nanomedicine, which not only improves the technique for investigation and remodeling the vascular structure by various different kind of treatment, this will also improve the ultimate results of procedures, endovascular procedures and adjunct procedures. This is the results of the angiogenesis by using stem cell therapy. And this is by using the nanomedicine technique to improve the cardiovascular illness problem. So we now have got different tools in our armamentarium to improve the prognosis in chronic limb-threatening ischemia or acute limb-threatening ischemia with good prognosis and preventing amputation. Now, this is my final slide. What I'm trying to show, in UK, we adopt a program called GAPT program, which means getting it right first time. Now, this program is led by clinicians. The senior clinicians, what they do, they analyze the results of individuals and institutions with regard to the treatment in any modality, whichever specialty you belong to. And then they recommend what treatment options or what management options or care pathway options that should be adopted in order to maintain an uniform and better results compared to individual choice, so that it can be translated to most of the institutions in the country in order to achieve that kind of the best result. So this has been endorsed by the Royal Colleges. This has been accepted by all the clinicians, and this actually has changed the outcome of treatment in various surgical procedures. So now I have already alluded to all the different factors which are necessary to develop this miracle vaccine so that amputation can be prevented. Thank you. Any questions?
Hi, Dr. Das.
Hi.
Thank you so much for that very excellent presentation. You did mention a few very important issues for early screening diagnosis in order to hopefully prevent amputations. I just wanted to make a comment that not very long ago, there was an article in JAMA, which was then picked up by New York Times in their medical section. And they just gave a questionnaire to thousands of primary care physicians about their knowledge of peripheral vascular disease. And the results were just horrendous. So I think, I know there are residents and perhaps medical students in the audience, but I think one area that we can all strive to be better is to teach our colleagues in the medical world to know about early screening and referral and all of that, so that hopefully we can break this cycle of amputation. Thank you for the presentation.
That is absolutely right. I think that is the reason why the vaccine miracle drug or miracle, includes awareness, raising the awareness with the trainees, doctors, and patients, everybody alike.
Thank you, Dr. Das.
Thank you.
I had a question. First of all, thank you for your presentation. I'm actually working on a paper with Dr. Oye about intraoperative decision-making to prevent amputations or to preserve limbs. And your presentation is really insightful and it'll go well with my paper. So my question was, if you had very limited resources, which components of your vaccine protocol, like if you had to just choose one of them, which single intervention would you roll out tomorrow to reduce amputations?
Yeah, that's a very nice question. I'll tell you what, the previous, I'm sorry, I'm forgetting his name. He alluded to awareness. Most of the problems happens because the awareness regarding an ischemic limb isn't there. Now, you talk to a patient, I think many times the patient knows better than the doctors or clinicians or anybody else what he is having. And we just ignore the patient's presentation. So, my coming back to, even as general practitioners are not fully trained to distinguish peripheral vascular disease from other causes of common causes of leg pain or other thing that happens in the community. So this is simply raising the awareness. If you have somebody got pain in the leg or somebody has got developed an ulceration, so a simple procedure like doing an ABPI, ankle brachial pressure index, and that has been very common these days in United Kingdom and I think in most of the European countries. And it just needs a handheld Doppler and blood pressure cuff and to do an ankle brachial pressure index. If somebody has got an ankle brachial pressure of above 60, 70, it is very unlikely that he has got ischemic limb, that he will lose his leg. So I would suggest that because of the scarcity of resources, this should be the first line care of these patients to avoid critical leg ischemia, which may end in amputation.
Thank you, Dr. Das. Thank you. So per Dr. Oye, we're going to take a quick, short tea break, and we'll be back in 5 minutes. for the next speaker. All right, thank you.
Thank you.
oh yeah, so it's supposed to be me. So Jill, I am going to, well, it's crazy.
Hey, Dr. White.
Hello?
Yeah, we can hear you now.
I say anything. So I've got a little schedule. So I was here last night and trying to get my schedule before I get out of here. We got to get a lot of work done.
Yeah,
And so today is fine.
okay.
So I don't know. Did Monique tell you anything about patients that I won't be able to start? It's either Tuesday, tomorrow, or Thursday for me calling. Maybe somebody with 10, 3 or 4.
No, I saw your note.
Let me ask them right now. That's the information I needed to know to continue.
She messaged me last night and said she was gonna be a little later
Okay.
than normal.
You can move the box and sit if you want to.
Oh, no, I'm fine. Hello, this is
Mary and Dr. White.
Hi, good morning.
Morning. Which day you guys said I can't start until 12?
Let me check with Katie. Just one second. She's right here. Which day can you start? This Thursday.
So you guys don't have anything.
You have 2 cases on the schedule.
And I can't start any earlier?
Doctor has 3 and Ra has 2.
Okay. What does tomorrow look like?
Tomorrow's busy. They came to. I think that's what more.
I'll call you right back. Hold on, please. Hold on.
Okay.
Okay, bye-bye.
Okay.
Hey, what's
No,
up?
he,
Hey, hey,
You ready to start?
again? All right, let me try it again. Call you back, okay?
We can hear you.
You can hear me?
I'll just put up. Yeah.
Hold on, don't put my slides up yet. I can't see anything. I'm not in. I just got kicked out again. I'll be flying blind. Hold on.
You're here. You're in the call.
they can hear you on your.
All right. Okay. Can you guys hear me?
Yes, Dr. Whyte, we can hear you.
Okay. Where are the slides?
They should be coming up right now. Can you see them?
Yep, I can. Morning, everybody. Am I ready to go?
Yes, you're ready to go.
This has been challenging. Hey, morning. My name is Dr. Whyte. I'm calling from Beckley, West Virginia. Thanks for joining me. I'm going to present the case of pedal revascularization, a case report. That pretty interesting that I had to do. Next slide. Objectives is basically present the clinical history and examination, identify procedural problems encountered, describe the solutions and stepwise technique and pros and cons of the approach that I use, and also what I took away from this whole procedure. Next. 73-year-old male, comorbidities, diabetes, neuropathy, coronary artery disease, peripheral arterial disease, and stage 3 kidney disease. I did a BK on him in 2018. I told him to come back to see me. He never did. He had mirror image disease now on the right side, presented with more like a 4 to 6 week history of gangrenous right foot ulcer. Seen a podiatry. I had some debridement. It's been on antibiotics. Next. His labs basically BUN of 39, creatinine was 3.1. And his vascular studies basically significantly below knee disease, monophasic findings. Next. The physical examination is dorsalis, pedis, and posterior tibial arteries were absent, but his femoral pulses were normal. And his popliteal basically was normal to decrease. Next. Problems with this patient, he did not want to have any contrast. He said he was afraid of going into renal failure. And he really asked to be transferred to another institution. And another physician had seen him before. I was asked to see him in consultation. I discussed the options with this patient. One of them was a CO2 angiogram. And I told him basically that below the knee, the sensitivity is horrible. And you still normally give these people contrast. Intravascular ultrasound, my hospital has it, but we don't have the size catheters. Obviously, I couldn't do a CTA or MRA runoff contrast. So I offered him a retrograde access, and I told him I'll use minimum contrast as possible. After going back and forth for a while, he agreed to proceed. Next. Important, I use this a lot, the angiosome concept, and what that does, it sort of helps me look at where I need to revascularize these people, which vessels need to be opened. And if you look back at this patient's ulcer, it was on the lateral aspect of his right foot in the distribution of the anterior and posterior tibial artery distribution. So basically, to get this to heal, he needs to have at least those two vessels opened up to give inline flow to the foot. Next. So since I wanted to have both vessels open up, what I did, I tried to retrograde access the posterior tibial artery, was occluded. I accessed the anterior tibial artery. Once I got into the vessel, I used extravascular ultrasound with fluoroscopy, no contrast. I turned the pedal probe longitudinally and watched the wire as I maneuvered through the lesions as far up as possible as I could go. Then I advanced my AT wire. Go back to the picture, please. This was all done with 2 cc's of contrast. And if you look right here, here's the wire going up, taking the normal course. And I basically say, okay, if that's the case, I did a little bit of contrast. 2 cc's is my wire going into the vessel. Next. I tried to pass a 0.35 Navi cross on glide catheter. It wouldn't go. So the next thing I did, I used a 2.0 220 balloon. I did a balloon angioplasty, opened it up. I brought a wire coming down from an anti-grade stick, and just another 2 cc's of contrast. I was able to see I was in the vessel, popliteal artery, tibial peroneal trunk. Now I could have stopped here because I knew from my clinical examination that this guy had normal femoral pulses and at least a normal to decreased popliteal pulse. But I had some concerns because to get his wound to heal, he needed at least 2 vessels, which is the anterior tibial and posterior tibial. I felt comfortable. I went back and I ballooned the anterior tibial with 3.5 millimeter balloon, but I wasn't really seeing the posterior tibial or peroneal really well. Next slide. So what I did, I went against my better principles. I did an anti-grade stick. I use another additional 2 to 4 cc's of contrast. That's the superficial femoral. Next. Popliteal artery next. And here it is. So now that I know my inflow below the knee is fine, I need to really define the others below. I tried to do the PT again, both anterograde and retrograde, with no success. Wasn't sure if this was the PT or this was the PT. I went down both of them, couldn't get in. I said, let me just stop. But here we go again, right at this point, you have a tibial peroneal trunk, peroneal high-grade stenosis. A matter of fact, occlusion. I was able to get through this by coming from retrograde manner. An anterograde manner with retro with a catheter up and down. This is a Navi cross. I was able finally to get through. Place the wire through this here. Then an angioplasty. Open this up next. Next. And now it's all the way open. Next. And what I could see really nicely here, I see collaterals coming off the peroneal artery that's now going to the posterior tibial artery, which was indeed occluded, as you could see here. Next. Next. No, go back one, please. Here, no, the next one, please, sorry. Right here, I wasn't too happy with this, so I went back with a 4x4 balloon, and I opened this up, and trust me, it was great. I didn't do another film, because what I wasn't going to do anything differently. I was happy with that. I got good opposition. So now we had 2 vessels run off. Anterior tibial, tibial peroneal trunk was fine. The peroneal was patent down to the foot, giving great collaterals to the posterior tibial artery. So at least, runoff is all about important to heal wounds. He had 2, not 3, and hopefully they should heal his wound next. Techniques and tips. I always tell people the ultrasound probe should be in your left hand whenever you do any kind of procedure. To me, I have been doing this for quite a few years, and I have become very facile using ultrasound because it really makes a big difference. So literally, you should position these patients from the belly button down to the appropriate leg and the groin on the other side. Get access with the probe. Turn the probe in a longitudinal manner. You don't have to use contrast. You could watch that wire by twirling it through the sheath as it goes into that calcified vessel. To me, that's a lot better because you could, if you can't get through the vessel, you could pull the wire out, you could shape the wire in the position you want, and go ahead and get it up. I like to use a Terumo. I really have come to like this. Good support, pushability. Next. Why the retrograde approach? I think always a shorter distance to the lesion, and the shortest distance to the lesion, you have easier pushability. Besides that, you have the cap that also is very, I should say, gives you a better chance to get through and get into the lumen. Wire control. You don't have groin punctures. You don't have the big hematomas that you usually get. I mean, that's so important these days. You don't want to give these people these retroperitoneal hematomas or big hematomas in the groin and take these people back to surgery and have to evacuate it. It's an added mobility. And you really limit the amount of contrast that you use. Next. Retrograde access. I mean, this was done years ago. First cut down was done 30 years ago. In 2000, got it more so Betty and Spinoza. They popularized it. Again, the features, the cap, the short distance, reduced collateral involvement, which I think is important, especially this one, because going in a retrograde fashion, you don't get to hit a lot of collaterals you hit as you come in from above. Next. Limitations on caution. CO2 angiogram doesn't really work well. That's why you want to go ahead and use the pedal. IVUS, again, catheters not available. Single vessel runoff. I sort of like this because when you have to go from below, coming from above, it's always important when you have single vessel runoff because you don't want to damage that target vessel distally. If you damage that target vessel distally, you're going to destroy the only runoff you have below the knee. And to be able to do pedal access, you have to have excellent ultrasound skills. I mean, it's safe. You could see what you're doing. And really and truly, it really is a lot better for the patient. Next. He received about maybe 16 to 18 cc's of contrast. Okay. I was able to cross him with a Terumo wire. Again, I don't want anybody to take Terumo as the only wire you could use. I've played with them all. Just get a wire you could use and a crossing catheter and get very facile with it. Again, ultrasound is great. Hemostasis, manual light compression, 15 to 20 minutes. Okay. This patient had a palpable pedal pulse when he was finished on the anterior tibial, dorsalis pedis. He had a biphasic signal at the posterior tibial. Plan for continued care. Have podiatrists see him, debride him, and have to be very careful of the fact that he may have osteomyelitis of that wound, and close follow-up is indicated. Next. Takeaway again. You have to do a good physical examination of these patients. And physical examination means you touch the patient, you examine the femoral pulse, you examine the popliteal pulse. I mean, really and truly, I did not need to do an antegrade stick to look at the femoral and popliteal. My clinical examination told me that it was normal. Okay, would have been less contrast to be used, if as I examine this patient. Again, just master ultrasound studies and just make sure the patient is prepped all the way through, but you really, 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 really need antegrade backup if you don't get through in a retrograde fashion. Next. Next. Questions? Hello?
Dr. Whyte, can you hear me? Hey, Brian.
Hey,
Brian, can you hear me?
I can hear you barely, Herbie.
All right, very well. Thank you
Yeah, we
very
can
much for the
hear
talk.
you.
Thank you very much for the talk. You well know that it's a great technique. Don't have a doubt about it. And actually could be helpful in the confines of rural America as well as challenge West Africa as a whole. So maybe we need to talk more about the technique. Again, the only downside would be availability of good ultrasound to do the procedure. Then obviously the contrast level is also minimal, and you don't have to do CT angiography, full CT angiography to treat that. So certainly great talk, and I think we'll see how we can assimilate this into a treatment armamentarium for some of our complex patients here.
All right. Any other questions?
But do you know, Dr. Whyte, can you hear me?
It's hard to hear, but go ahead. I'm listening.
You know, I'm a big hybrid person, right?
Right.
What are your feelings about severe popliteal artery occlusive disease, and you come in retrograde from the PT when you have great burden, plaque burden in the popliteal artery or in the tibial trunk. Don't you think it'll be better in those cases to do endarterectomy with patch?
You know, I try, Herbert, you know me, I do as much as I can in the vascular. And I mean, there are tools out there. Like, for instance, this guy could have done well if we had a good atherectomy device at Raleigh. You know what I mean? CSI.
Correct.
I mean, for those things, they were great for calcium. I'm a great advocate of atherectomy. If on endovascular procedures, I don't have a problem doing an endarterectomy of the popliteal or those tibial burdens. But the problem is, if you have to redo these guys again and you try to cut them and go in, then you know what I mean? You always run into a lot of trouble. I mean, the disease is so bad, calcified wise, especially where we are, that again, I try to do as minimum as open as I can because of reoperations and redoing those areas.
Sure. Okay. Would shock wave would have been helpful for this patient?
Yeah, but they don't have, if I'm not mistaken, they don't have a 3 shockwave, do they? I don't think they have a 3 millimeter shockwave.
Yeah, they have a 3, 3.5 and up. Yeah, they do.
Yeah, but I didn't use that. I figured that I used the balloon angioplasty. Probably in hindsight, maybe shockwave would have been even better to use on this patient. Yeah.
Correct. Yeah. Very well. Thank you very much for the opportunity. Any more questions for Dr. Whyte? Yeah. Thank you, Brian. Appreciate it. Thank you so much.
Okay, buddy. Thank you.
Yeah. That goes again to tell you all the speakers you heard today. The most important thing when you see a patient is what? Anybody? Most important thing when you see a patient is history, 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 history. The next is physical examination. Like he talked about. There are Paul's here. He does the procedure by going from the ankle or foot. And the advantage of that is you must have a good ultrasound machine. So when you put the ultrasound on the top of the foot and you put a needle, a small needle into that artery with ultrasound, you're able to watch a wire go up the leg. Okay. And when you do that, then you're able to manipulate the wire all the way up. Then you can now put a balloon to open that artery. That's a good technique. You use less dye, okay, which is a good thing. I do the same thing, but I do a lot more stuff to make sure the patient does not come back, or if I can. So, but it's a great technique, especially it's a technique that we can, the typical average person that we train here can do that without having to do open surgery for cancer. That could be a good tool we can use for our financially challenged patients. So something we could do. So thank you so much. Yeah.
Thank you, Dr. Whyte, and thank you, Dr. Oye. Our next speaker is Zainab Khan, an MS3 student who will be talking about the management of mangled extremities. Zainab, you have the floor.
Dr. Cohen's one of my medical students. She's 4th year now, I believe, and she was talking about mangled extremity. Okay, let's take a look.
Start the broadcast. Hello, everybody. Good morning. Hello, Dr. Oye. My name is Zainab Khan, and thank you, Dr. Oye, for this opportunity. Without further ado, I would like to begin with my presentation. Today, we are going to be discussing a challenging and high-stakes topic in trauma surgery, the management of mangled extremity. And we will be walking through what this injury entails, how we assess it, and the critical decisions between saving a limb and amputation. So what is a mangled extremity? It's what we can ask what exactly what is a mangled extremity. So we can imagine it's an injury so severe that the limb is almost unrecognizable. We are talking about high energy traumas like a car crash or industrial accident that devastates not just the bone, but at least 3 out of these 5 systems, like muscles, nerves, tendons, blood vessels, and soft tissue. The damage is so extensive that historically the only option was often amputation. This isn't just a simple fracture, it's a catastrophic event for the limb and the patient. Okay, now you might wonder how common this is. Fortunately, mangled extremities are relatively rare. Studies suggest that they occur in only about 0.2% to 1% of major trauma cases. But this number isn't fixed. It fluctuates based on geography, the types of accidents common in that area, or even in the definitions used in research. In war zones with poor or places with poor road safety, the numbers can be very high. Speaking of road safety, there is a silver lining. Over the last 2 decades, advancements in automobile safety features have significantly reduced the fatality rates in high-speed accidents. However, when survivors do sustain these complex limb injuries, the challenge for us as clinicians begins. A key tool we use to standardize that challenge is something called Mangled Extremity Severity Score, or MES. Which brings us to our next point. Before we dive into those scores, let's briefly look at some clinical examples. These images drive home the reality of these injuries. It's chaotic, it's destructive, and forces us to make a rapid, life-altering decision. So what is a MES score? What is the MES score? Okay, it's a critical decision-making tool to help us cut down through the chaos. It assesses the injury on the basis of 4 pillars. Number 1, the extent of the skeletal and soft tissue damage, the degree of limb ischemia or lack of blood flow, the patient's state of shock, and the patient's age. The grim reality is that an attempt to save the limb with a very high MES score can lead to major complications. Multiple surgeries or often a delayed and more traumatic amputation anyway. Even if salvage is successful, the patient may be left with severe disability. So you might also hear about other scoring systems like a limb salvage index or LSI. While MES is more general and widely used score, the LSI was developed specifically to predict the viability of the salvaged limb. So I'll just briefly describe how LSI works. It's a little bit more detailed as compared to MES, and it has 6 key factors. Number 1 is arterial injury. So how severe is the damage to the blood supply? Number 2 is the venous injury. Is there any damage to the veins that will cause swelling? Number 3 is muscle ischemia. How long have the muscles been without the blood flow? Number 4 is skin and soft tissue, which is what is the extent of the crushing and soft tissue loss. Number 5 is bone injury. How complex is the fracture? Number 6 is neurological injury. Is there a loss of sensation or motor function? Each of these are scored and the points do add up. For both of the MES score and the LSI, the higher the score in both scoring systems, the less likely the limb can be salvaged, or in other terms, it indicates towards amputation. But the takeaway here is that these are the tools, not oracles. MES gives us a rapid initial state assessment, while the LSI provides a more nuanced tissue-specific evaluation. They guide us, but they don't make decision for us. This brings us to a very crucial modern interpretation. Over the last decade, surgical techniques have advanced remarkably. Microsurgery, bone transport, soft tissue coverage are better than ever. So a MES score of 7 or higher is no longer an automatic death sentence for the limb. We now often use it in conjunction with LSI and, most importantly, our clinical judgment. We also have to think about amputation itself. It's just not a simple cut. We have to preserve adequate length, soft tissue for a functional stem. And modern prosthetics have become incredible with osseointegration, where the implant fuses with the bone, and even bionic hands that attempt to restore sensation. So finally, we have to consider the whole patient, their age, their job, their social support system. Like, for example, a laborer might prioritize a predictable amputation over prosthetic limb, when it's uncertain that salvage process, when it's a very uncertain salvage process, and eventually it will lead them to a very painful, non-functional limb anyways. Treatment. How do we actually manage these patients? It all starts with ATLS, Advanced Trauma Life Support. The patient life comes first. We resuscitate and stabilize them. We control the bleeding with direct pressure. Our tourniquet can be useful and a life-saving measure here, and it's temporary as well. Once the patient is stable, we do a thorough secondary survey to uncover all the injuries, because a mangled leg or an extremity might distract us from a more life-threatening abdominal or a head injury as well. If we decide to attempt the limb salvage, it's a marathon, not a sprint. The process involves series of precise steps. Like a radical debridement, we must aggressively remove all dead and contaminated tissue to prevent infection. Fracture stabilization, usually with an external fixator initially to hold the bone in the place. Vascular repair, a microsurgeon must repair arteries, veins to restore the blood flow. This is often the most time-sensitive step. Soft tissue management, we use skin graft, flaps, or vacuum-assisted closure devices to cover the wound. Infection control, aggressive antibiotics are must. And finally, rehabilitation starts early to preserve the joint function and strength. On the other hand, if the decision is for amputation, the goal is to create a well-healed functional stem. We carefully select the amputation level to maximize the future prosthetic use. The surgical technique is very meticulous, focusing on nerve handling, muscle balancing, and creating a durable soft tissue envelope. Post-operative care is focused on pain management, preventing infections, and very importantly, initiating rehabilitation almost immediately to prepare for a prosthetic fitting. Regardless of the path chosen, the journey doesn't end in the operating room. Long-term care is very crucial. This involves intensive physical therapy to regain mobility, occupational therapy to adapt to daily life, and just as importantly, psychological support. An injury this traumatic carries a very heavy emotional toll. Addressing body image issues, depression, is a key part of the successful recovery. Both of the paths are very fraught with potential complications. The most serious include deep infections like osteomyelitis, blood clots, pulmonary embolism, and even multi-organ failure. Common complications are wound infections seen in over a quarter of cases and non-union of the bone. Shockingly, in hand replantation, nearly half of the patients may need a secondary reconstruction. Mortality, though rare, can occur at any stage, which can be during the initial surgery, post-operatively, or even during a later reconstruction. My information today was gathered from very reputable sources, including AAOS, Global Crown Grounds at the University of Washington, and several peer-reviewed journals. All of them are listed here for your reference. Just a quick conclusion. Managing mangled extremity is one of the most difficult challenges in trauma surgery. It requires rapid, systematic approach guided by scoring systems, but ultimately dependent on seasoned clinical judgment and a deep understanding of the patient as a whole person. The goal is always the same, to provide the best possible functional and life outcome, whether through a heroic salvage or a well-planned amputation. Thank you, everybody.
Thank you, Zainab.
Thank you.
Thank you for your messages, Dr. Ebi Mary.
Thank you so much, Doctor. Thank you again, Dr. Oye, for this opportunity. Thank you, Ibrahim, also for coordinating everything.
Thank you, thank you. All right. Oh, our next speaker will be Dr. Emmanuel Edafe. Dr. Edafe is an accomplished interventional cardiologist and senior lecturer in the Department of Medicine at the University of Port Harcourt. Dr. Edafe is known for his expertise in...
So anyway, the complications are
Sorry,
real.
Dr. Ali. I think there's some network issues there. Hello? All right. So we'll move on to Dr. Edafe's presentation.
Okay, thank you.
Dr. Edafe is joining us right now. Hello, Dr. Edafe. Are you there? You're muted, sir.
Dr. Edafe, for those who don't know him, is an interventional cardiologist who is practiced out of Port Harcourt and also does come here occasionally for some work. So he's well trained and well traveled within the Nigerian context.
Yeah, thank you very much, Dr. Oye, for the kind invitation and the privilege to be part of this 8th edition. I remember several years ago when you started the first edition, I was there. Thank you so much. So,
oh, horrible.
I will be talking on trans-arterial liquids and embolization. This was a case that we did at Port Harcourt, the University of Port Harcourt Teaching Hospital, and Dr. Shirley, myself, and also the urology team were also part of the collaboration to
By the way, we'll have all these presentations on YouTube channel. So due to difficulties with this, you can always go back and listen to them. If you like any of the lectures, you want to listen to them in total and see the slides, you'll be able to see them. I'm sorry about the internet connectivity in Bayelsa today, but that will be there. And there'll be a host of other previous programs we've had in the past, not only the Endovascular Conference, but global ground rounds, which we do every 3 months, where you could see my medical student, fourth year medical student, presented last case before Dr. Edafe, and you can see she did a great job doing that. So again, our students are trained to do this. They work with us very closely and able to do this flawlessly usually.
Okay, I'm back. Okay, next slide. So in recent years, cardiology has experienced the most important renovation, a revolution, and also expansion, both in diagnostic and applications in interventions. As a matter of fact, the father of interventional cardiology, Andrew Gruzzi, was actually trained as a radiologist. So if your catheter can go into the coronary, to do any intervention, those catheters can be extended to any part of the body where there are vessels. And that is what we, the cardiologists, are doing. So the goal of the embolization is to obtain the vessels to be occluded and also to reduce blood supply to that vessel so that subsequent surgery can be done without minimal trauma of blood loss to that particular tumor, as in this case, we will see. Next slide. Okay, so trans-arterial liquid embolization is an endovascular technique I've been discussing with Oye for several years now, where liquid embolic agents are delivered via the catheter to the target vessels to achieve occlusion. It is used in several conditions like vascular malformation, hemorrhage, tumor, or even endovascular leak after deployment of your cover stents. Next slide. So there are several materials that can be used in this. Common among them, you can use coiling especially for AV malformation. Then also you can also use the liquids such as the glue and the oni. In this case, that I will summarize very soon is the oni that we use to get it done. You can also use chemoembolizing and also other sclerotic agents that are also available. But one thing about us here is that many of these embolic agents are not available in the country. Currently, we have coiling, and coiling come in different 035, 035, 018 coiling, and the rest. I remember a case that we wanted to use a particular 035 coiling, we couldn't get it, and we have to get switched to other agents. Next slide. Okay, so the principle of embolization is clear. If you are using things like coiling, you have to depend on the coagulation pathway, so that when the coil gets to the target point of the vessel, the body initiates coagulations, and there will be a clot around the coil. But if you are using things like the ONI, which is produced by Medtronic, you don't depend on that, and you don't depend on the body system to get the coagulation pathway activated. Once you miss the ONI with the DMS liquid, and you inject it and it gets to the target point, it just, as it gets to the vessel, it just precipitates on the vessel, and it forms a solid mass which occludes the vessel, and it does not depend on the body intrinsic coagulation pathway. So it preserves that, and this can be used for patients whom you may not need the intrinsic anticoagulation pathway to go ahead with. And the only comes in two formulations, as we have it here. One is the 18 concentration and the 34 concentration. It depends on what you want to use, the size of the vessel, and the extent of what you want to inject. You can go for any of that to achieve your aim. Next slide. So the indications for liquid embolizations are many. From at the level of oncology, we talk about renal cell carcinoma. For example, there is a patient we have currently that has a renal cell carcinoma, bladder cell carcinoma that are inoperable, and we work with the urologists and other surgeons to see how we can debug this tumor by taking out the blood supply. Then things like GI bleeding, trauma, postpartum hemorrhage, then AV malformations, and are also part of the, then also endovascular leak in between two stents, or maybe probably a shift in the cover stent or not properly deployed cover stents. You can use this method to seal up the leak, the endo leak that may come up. Yeah, next one. Next slide. So the liquid agent as we use here is the ONI. One thing about the ONI is that, as we said, it precipitates, and it does not depend on, it doesn't depend on the coagulation system that that we have in our body. Next slide. Yeah, so the mechanism, I've explained it. Next slide. Next slide. Okay, so the case summary here is a 70-year-old young lady. She had sickle cell anemia, and she had this presented with a very huge right adrenal mass that is compressing on both the liver and the kidney, pushing the kidney down into the pelvic region. And not just only that, the patient keep having persistent pain, and you can grade the pain on a scale of 8 and 9 on the basis of 10, and that has prevented her from her daily schooling and daily routine activity. And the pain is present all the time, but also preventing her from sleep. That was why she presented, and we investigated. The abdominal ultrasound showed that she had a huge mass, which they pointed as adrenal. Then a CT that was, you can see here, show that she has also a very huge mass that is pushing on the kidney and also the liver. Next slide. Next slide. Okay, yeah. So you can see the mass here, and this is the only that we use for the patient. I think we have to miss the DMSA with the ONI for us to achieve the required concentration. Next slide. Next slide. Okay. So this is the angiography. This is the angiography, the same CT angiography. You can see that the right kidney has been pushed down. The reconstruction of the CT, you can see the adrenal artery that is going to supply the tumor has expanded, and it has a lot of collateral that builds around it to supply that the tumor. Next slide. Okay, so this is the during the ONI embolization. The first thing that we did during the procedure was first we identified the celiac artery, also identify the two renal artery, the left and the right renal artery, by injecting our dye into that to identify, visualize those vessels. Then also the mesenteric artery, we also identify it. Then turn our catheter to the horizontal and identify the adrenal artery. Then after we identify the adrenal artery, the second step was, as you can see, the slides that you are having there are not showing, but the one I have here are showing. So no, go back. Your slides are not showing. The one I have are all video images. Although I will manage with this, I'm not the one controlling it. If I was the one controlling, I could have shown you the video images. No, it's not showing here, but my own video images are showing. So what we did next was that, those people to calm down. What we did next was that we connected the micro catheter. We took the micro catheter into the adrenal into the adrenal artery. Then we image again and found out that there are a lot of collaterals coming from the inferior phrenic and also from the renal. But one thing we decided was that we can't embolize everything. So we just take the 34 concentration of the ONI and injected directly through the microcatheter and embolize the whole of that territory where the catheter is. And we got a very good result. Then we take out our catheter and injected and find out that that particular adrenal artery was totally occluded. Next slide. Post-embolectomy, it was totally occluded. Yeah, this was the injection. I think our own images are showing it was totally occluded. Next slide. So as we said, you can see that this is the renal artery and this is the adrenal artery that we took. We only took one of it and take it out. There are still other collateral coming from the renal artery and also from the inferior phrenic. We left that, but the bulk of the supply was from the adrenal artery that we took off during the embolization. Next slide. Okay, so the techniques are simple. We did the ultrasound, we did the CT, identified the major feeding vessel. Our access was through the femoral, and we passed a microcatheter to get to the target point, and they prepare our solution, then inject it into the feeding vessel, and it got the feeding vessel totally occluded. And we confirmed patient was hemodynamically stable. Although there was some pain when the injection came in, that was expected because as a coronary interventionist, you know very well that when an MI happens, one of the typical presentation of MI is pain. So you take out a vessel, so the patient will have some abdominal pain, which we manage with pain relief, and the patient got far better hours after the embolectomy. Next slide. Yeah, so post-embolectomy, patient received some fluids and was hemodynamically stable, and we discharged the patient home the following day. Next slide, sir. Yeah, next slide. Okay, so 4 weeks after the embolectomy, the patient has to return back to the urology ward of the University of Port Harcourt Teaching Hospital, and we have to go in. I didn't scrub, but I was in the theater with the surgeon, and they opened up. It was a bloodless field. We saw all the arterial kids coming from the medial aspect of the tumor. They are all obliterated, and all you just see dead arterial territory all around that. And it was easy for the tumor to be free from the kidney without any stress to the surgeon, and the kidney is fine. Then also they freed the tumor from the attachment to the liver. Yeah, they noticed they had some very minor bleed when it took it from the liver. But the medial and the inferior pole of the tumor, there was nothing like a bleed. But the surgeon did a tying on the bed, and we can see all the arterial territory that are all dead with clotted blood around that territory. So the tumor was taken out, and patient hemodynamically stable, and moved the patient to the ICU for that day. The following day, patient was discharged from ICU to the urology ward, and subsequently discharged from the urology ward, and very stable. Next slide. Yeah, so the advantage of using ONI is that you don't depend on the arterial system, the anticoagulation, the coagulatory pathway of the patient, and also it gives you a fast result as fast as possible. And it gives you, and another thing about ONI is that it precipitates, it doesn't attach itself to the catheter like the glue, which can, if you don't withdraw it as fast as possible, which you can experience the catheter being hooked to the glue. Next slide. Okay, so there could be complications. One of the complications here is that patient may have pain, may also have fever. Yeah, when we embolized this patient, there was pain, and but there was no fever. Patient had pain, which we managed with pain reliefs, and the patient got better hours after. So there could also be that, but we have not experienced it. Then contrast allergy and nephropathy. On that was why we did the renal function before we took it out. Then another thing is that when you are, because this is an adrenal tumor, when you hold adrenal tumor, you release a lot of catecholamine, so the patient blood pressure may surge, and also the heart rate may also surge. But because we embolized this patient, we didn't get all that during the post-embolectomy surgery. And another thing about that is that we try to preserve the kidney because one is a sickle cell patient. We don't want the patient to go with just only one kidney. Yeah, we knew that people can live with one kidney, but this is a patient who already generally is already compromised with the kidney. So we try every means to preserve the two kidney. That was one of the reasons we went for the embolization. Then another reason here is that we didn't want this patient to lose so much blood during the surgery, and that also played out during the surgery that multiple bleeding were not there. The line of the medial and the inferior line, there was no bleeding around there, just a dry feed. And the posterior aspect of the tumor where it gets attached to the vessels from the liver, the patient has some minimal bleeding, which the surgeon easily controlled, and it was fine. Okay, next slide. Okay, so the recovery and follow-up were also very good, and we follow-up, and the patient has been on follow-up since after the surgery and has been hemodynamically stable. She has returned back to her schooling, and she's doing fine. Next slide. Okay, next slide. Okay, so prognosis by liquid embolization is more than 80% good, and in a very few percentage of them, sometimes up to 20, the results may not be so fantastic. But so far, we have gotten a good result. Thank you very much. Next slide.
That's the end of the presentation, sir.
Yeah, that is all. Thank you.
Thank you.
So if there are questions, I think I'm here. I've finished.
Yeah, we're waiting for Dr. Oye to put on his microphone.
Yeah.
Can you hear me?
Yes, sir. I can hear you,
Can you
sir.
hear me?
Yes, I can hear you,
Very
sir.
well. Thank you for the presentation. Very well.
Thank you, sir.
Yeah. Thank you for the presentation. And interesting case. The comments I would have are such. Number one, obviously in this environment, that was a great way to have taken care of the procedure of the case in question. The other alternative to your intervention would be robotic surgery, where you do robotic adrenal surgery, tumor resection, and that way also you probably don't need to do embolization prior to that, I don't think, because your visualization is usually very good with robotics. So that could be another way to look at it. But I don't think you'll have
Yes, sir. Thank you. Yes.
robotics. So in your
No.
climb, this is actually very good. Questions for Dr.
Thank you, sir.
Okay. Yeah, thank you so much. Thank you, Dr. Edafe. By the way, Dr. Edafe.
Thank
Dr.
you,
Edafe, still
sir.
there?
Yes, sir.
Hello? Yeah.
I'm here. I'm here, sir. I'm here with you.
Here we've lost connection with Dr. Oye. Move on to introduce the next speaker, Dr. Duangnapa Cuddy. Dr. Cuddy is a board-certified vascular surgeon at Indiana University, Bloomington, and assistant professor of surgery at Indiana University School of Medicine. She's a fellow of the American College of Osteopathic Surgeons and a registered physician in vascular interpretation. She's widely recognized for her expertise in limb preservation and vascular reconstruction, as well as her humanitarian work, for which she received the American College of Humanitarian Award. Today, she'll be sharing a compelling case from the limb team, showcasing the power of multidisciplinary collaborations in saving limbs and improving lives. Please welcome Dr. Cuddy.
Thank you. That's very kind introduction. Hopefully everyone's hearing me okay.
Yes.
Okay, wonderful. All right, and looks like, I think my screen should be popping up right there, my slide.
Yes, we can see your slide, Doctor.
Thank you. So yes, I would like to go ahead, start presentation about the limb team and limb preservation as well as limb loss situation. I do not have financial disclosure, and these are some of the objectives. Would like to start with a case presentation. This will be a great case. The reason I chose this case is because it is very well representative of the patient that come in with situation of facing limb loss versus limb salvage. He's a 66-year-old man that has only known past medical history of hypertension. He had recent hospital admission at another facility with small bowel obstruction, and he was conservatively treated and then discharged home on oral antibiotic. He presented to our hospital facility approximately 1 week after discharge with increasing abdominal pain and CT scan was found to have perforated bowel. As per patient's wife, he also has been experiencing left leg cool and numbness approximately 1 day prior to presentation. We did CT angiogram with runoff, which was found that he had acute thromboembolic occlusive disease of aorta extending to left iliac profunda femoral artery and distal SFA popliteal, and without any runoff to below the knee vessels. So these are some of his CAT scan. You can see this is aorta that has acute thrombus inside, extending thromboembolic occlusive disease, near occlusive disease to iliac artery. And it was also extending into profunda femoral. And there was a little bit more reconstitute at the distal SFA, but more just right below, more distal without any flow through it. Below the knee, there was no vessel runoff. So the patient went to operating room with general surgeon for exploratory laparotomy and bowel resection. At the same time, another vascular surgeon went into operating room with the general surgeon and did diagnostic fasciotomy to left lower extremity, but no intention of revascularization. So the patient was transferred to ICU. He remains intubated on heparin drip, and he was planned to have the second look by general surgery team on the next day. And that's when the patient was transferred to our team for continuing care. So he remains intubated. At the time, his CK was less than 1,000. His lactic acid by venous was 0.5. So what my team decided to do the next day is, by clinical examination, he seemed to have perfusion of left lower extremity that has been stabilized by the heparin drip. The perfusion and skin perfusion seem to be okay, warm all the way through, just right below the knee, but from mid-calf to distal foot appear to be cool and very pale. We were not able to do neurological and functional exam due to intubation and sedation. At the time, there was no clinical sign of toxic ischemic limb threatening. So my intention at the time is to pursue thrombectomy of left lower extremity and also preserve the profunda femoral, to open up profunda femoral artery, and hoping that this will give perfusion and preserve the tissue below the knee, hoping that if we would end up below the knee amputation, functionally, he may be preserved and have a better quality of life. So at this time, we know that the probability of functional restoration would be very low due to ischemic time has elapsed more than 72 hours already. So reviewing his comorbidities at the time of hospitalization, he has acute thromboembolic with ischemic limb of left lower extremity, iatrogenic open wound from fasciotomy, acute abdomen bowel perforation. He also had pulmonary complication, sepsis. He was also suffered from anastomotic leak with bowel resection, acute hypoxic respiratory failure, acute kidney failure, which requiring continuous CRRT, bacteremia with E. coli from the bowel perforation translocation, acute blood loss anemia, severe thrombocytopenia. His platelet was dropped to the level of 20s and 30s, elevated LFTs, probably likely due to liver shock, severely malnutrition, GI bleed, and also mediastinal hematoma from the hemodialysis catheter complication. So his perfusion of left lower extremity remains compromised with signal to popliteal pulse only, and continue to have occlusive small vessel disease below the knee. At this time, he continued to have no clinical sign of toxic ischemic limb threatening. So we made decision to not doing any urgent amputation. Multiple blood products, rewarming, and heparin drip was the mainstay from vascular standpoint in supportive care. And continue with the primary abdominal, intra-abdominal sepsis treatment. At this time, we're calling for a multidisciplinary team or limb team that we had formulated in our institution at the time, including vascular surgery, general surgery, hospitalists, infectious disease, nephrology, interventional radiology, nutrition, PT, OT, social worker, case manager, chaplain, nursing leader team. The patient overall length of stay, approximately 31 days, and he was discharged to acute rehab. So 2 weeks after his discharge to rehab, unfortunately, despite that his pulmonary and intra-abdominal sepsis infection was optimally treated, his fasciotomy wound became infected. So he was readmitted to hospital to underwent the second stage below the knee damage control for sepsis with guillotine amputation, and then stage above the knee amputation. So he was discharged home to rehab on post-op day 7. He was doing well post above the knee amputation, wound healing very well, PT rehab, and no stump complication upon follow-up in the next 6 months. So I would like to discuss a little bit about the definition of standard of care. This was taken by the emergency medicine articles that in the modern of 21st century medical and surgical care, we commonly seeking for evidence-based to guide our therapy, and difficult sometimes patient various surrounding circumstances. Due to every circumstances may be unique and not exactly described by each scenario for the standard of care or evidence-based that we are seeking. Therefore, the conclusion of article was made that precisely defining the medical standard of care is frequently difficult and sometimes can be controversial. In many cases, there's no clear predetermined standard that will exist. The indication for fasciotomy, the only one listed and well accepted for doing fasciotomy is acute compartment syndrome. Unfortunately, the diagnostic fasciotomy that is not accompanied by revascularization, there never be any documentation to support that it is necessary nor sufficient if the limb can recover from septic shock and from intra-abdominal septic source. So this is in the cohort of 107 patients that shared this year in the non-trauma related, including prophylactic fasciotomies, nerve injury, wound infection, which related with mortality ranging from 23 to 32%. So there's a recent published in the patient who underwent major limb amputation, who were considered to be in dementia or frailty that have proven to be a very poor outcome. So the study was obtained from a large patient sample, over 46,000 patients. It is a claim-based frailty index was utilized in the Alzheimer's disease-related dementia and the frailty due to medical comorbidities. So this study has shown that doing major amputation in patients with moderate or severe frailty can lead to very poor outcome, including high mortality, readmission, and some complications that require later revision. So when exactly do we do these major tissue loss surgery? So it's been several publications in the academic world that it's not uncommon at all that people will delay amputation, definitive amputation for the patient in many circumstances, including trauma and also vascular related pathology. So evidently, none of this study has shown that delay definitive amputation has increasing mortality for the patient. I would like to mention a little bit about limb team. How do we get ready? The number one factor is wound healing factor. When we do revascularization or making decision to remove the tissue, the limb, number one, we have to consider infection source control and systemic infection as well. If the infection is still going on and not being controlled, likelihood that major tissue removal, the wound healing would be very difficult. If there's any foreign body removal as a source of infection, that should be also considered. Vascular perfusion, that would be very important for the wound healing capacity. Medical comorbidities of the patient, if the patient would be sufficient for medical management to support the wound healing. Mobility and rehab potential for the patient. We have to remember that removing limb, it will not change the patient's rehab status. We want to preserve the patient rehab status and quality of life. Nutrition, immunity, and lastly, but very important as well, psychosocial and family support surrounding the patient in both before the limb removal and also after the limb removal status. Surgeon who is performing the surgery, in this case, vascular surgeon, and multidiscipline team for all of the involving specialists. The end goal is we would like to improve or preserve the patient's quality of life after the limb removal. The patient's own outcome measured. This is even though before the decision of limb removing surgery. Value-based vascular surgical care is something that we need to consider in this modern practice in vascular surgery. The adaptation of principle of value-based healthcare was taught and widely taught by Dr. Hamish Lang. He was a pioneer and advocate for value-based medicine at Swansea University in UK. The focus based on the treatment, not just treating the disease, but we are treating the whole patient. This is the value of healthcare and not just the disease care. In turn, value-based healthcare and vascular surgical care can help decrease cost of healthcare. It is the principle of prolonged life, increasing lifespan versus increasing quality of life for the patient. I would like to pause here to give opportunity if there's any question or discussion.
Yes, sir.
What was that, Dr. Roy?
Yes, is Dr. Cuddy there?
Yes.
Dr. Cuddy,
Mhm. Yes, I'm here.
Dr. Cuddy. Yeah, thank you very much for the presentation. We appreciate your thorough presentation. We're getting the feedback from your presentation that we need to think about a limb team as a multidisciplinary effort to prolong the life, quality of life of these patients, including frail patients. Your patient in question had significant other comorbidities, which were very troublesome. However, in the face of an occlusion or thrombotic occlusion of the iliac arteries, thrombotic occlusion of the profunda and the SFA, the primary initial surgeon, vascular surgeon that is, should have at least done a femoral exposure, Shadi that was done. So that way, so I think that would have been something to have been, doesn't make any sense at all, as you well pointed. That's not a good indication. Diagnostic fasciotomy without revascularization is pointless, and I think that should not have been done. Dr. Cuddy, you still there?
Yes, yes. Thank you, Dr. Oye. I think your question or comment was a little bit cut off in the beginning. And from what I gathered from your comment was that, yes, limb team is very important. I absolutely agree with that. From our experience that we've been formulating and utilizing the resources of limb team, multidisciplinary care, we had decreased the rate of amputation of the patient from approximately, we reduced the rate by over 50%. In overall cases, that the case index that collecting prior to the limb team formulation and formation, we did amputation above and below the knee for various indications for approximately 230 cases per year. But after the limb team formulation, we did reduce in the first year into 120 cases. And the second year, we reduced it to 58 cases. So it was significant reduction of number of limb loss in the patient in the community. But yet, it is very labor-intensive resources, and everyone had frequent meeting. In one case, hospitalization, sometimes we had to meet 3 or 4 times, and well documented across the board. After the limb conference, we documented in the chart. So when the new hospitalists or new subspecialties that takes over into the patient care, so everyone will be kept in the same page. That's the key. And as well, the treatment and multidiscipline support continue to carry on to bridge the gap between inpatient and outpatient as well. So that's also very important and extremely important with the simultaneous medical comorbidities management as well.
Dr. Cuddy, thank you for
Thank you very much.
presentation. Can you speak on, with the limb team, what is the one single most important thing that cuts your amputation rate by 50%? What is it that they're doing?
What we did was, number one, we identify what could be a potential failure for limb salvage. A lot of times, because everyone is doing a very good job, the interventionalists were trying to get all of these blood flow to go to the leg and doing things, podiatry trying to do the wound care, ID doing antibiotic and everything. So everyone is already doing a great job and attempting at best, but we're not doing it together. So the key is we're bringing all of these resources and people that are trying to already do a good job and trying to get together in the same page and consider each patient is unique. For example, the patient who has diabetic that is not very well controlled. So how do we approach that? If they come in with critical limb ischemia, with wound, with ulcer, non-healing, with sepsis, and their diabetic is not controlled, their A1C is 12 or 13. There's a very large study in that case that diabetic not well controlled is also has detrimental negative impact on revascularization and patency intermediate outcome of revascularization. So the timing, when do we do things? Infection source control, yes, very important. Podiatry, we closely work with podiatry and conference and take into consideration. Some cases we have to do revascularization first. Some cases we do podiatry debridement first. Some patients, we need the ID to be on board, very nutritional support and psychosocial support, chaplain with social worker with family support, and also the patient's mobility and PTOT to rehab, to mobility for the patient before revascularization. Not only after revascularization, but before revascularization that we introduce in PTOT onto the patient. So with all of those components are simultaneously working together. Those is not just one single factors, but everything when we work together is maximizing the positive outcome for the patient in our experience. Thank you. That's a great question.
Thank you, Dr. Cuddy. Any more questions? No? Thank you, Dr. Cuddy. Appreciate you.
Thank you, everyone.
Thank you, Dr. Cuddy.
Thank you.
Thank you. Bye-bye.
All right.
All right.
So our next speaker is Dr. Mojtaba Gashti, a highly experienced vascular and endovascular surgeon practicing in Florida and serving as Chief of Vascular Surgery at MedStar Union Memorial Hospital. Dr. Gashti holds fellowships in both the American College of Osteopathic Surgeons and the American College of Surgeons, and is credentialed as a registered physician in vascular interpretation. With decades of experience and expertise in open and minimally invasive vascular techniques, Dr. Gashti brings a wealth of experience in limb salvage, complex peripheral interventions, and multidisciplinary vascular care. Today, he will present on critical limb ischemia and limb salvage, offering us deep insight drawn from his clinical practice and surgical leadership. Please join me in welcoming Dr. Mojtaba Gashti.
All right. Can you guys hear me?
Yes, I can hear you, doctor.
Well, thank you so much for that kind introduction.
Yes.
I would like to thank Dr. Oye and the organizing committee for the invitation. I was asked to present on critical limb ischemia and limb salvage. And we've had at least a couple of other talks already today, which have referenced this very important issue. Next. So peripheral artery disease affects almost 12 million people in the US and more than 200 million people around the world. About 150,000 amputations take place yearly to critical limb ischemia, and 2 million people with critical limb ischemia are running around in this country. Next. We have known for a long time what the risk factors for PAD are, and this is just one of the many studies. And you can see if a patient smokes, has diabetes, family history of coronary artery disease, high cholesterol, hypertension, they all have higher incidence of peripheral artery disease shown with the red bars. Next. And we also know for majority of cases, peripheral artery disease is a disease of the elderly. We don't usually see a 40-year-old with critical limb ischemia, exception of some rare conditions. But these are just a couple of studies that show that as we all age, the risk of developing peripheral artery disease increases. Next. What is important is peripheral artery disease is not a benign condition. We need to know this. We need to, again, I think we have residents and perhaps students in our audience. We need to understand that we cannot just blow off peripheral artery disease if the patient is in a situation where we're not going to intervene at this time, at least not for their claudication or their other symptoms. Because the 5-year mortality, relative 5-year mortality for PAD is higher than breast cancer, colorectal cancer, and is only second to non-Hodgkin's lymphoma. Well, it is not because these individuals are dying because, they have a sore in their toe. No, because they have other major cardiovascular risk factors. PAD should alert all of us to look for those other risk factors. Next. And if you develop critical limb ischemia, then your 5-year mortality rate goes up to 61%. A lot of these individuals die from coronary artery disease, cerebrovascular disease, aneurysmal disease, other cardiovascular diseases. Next. And that is because we have known for a long time that peripheral artery disease is a systemic problem. Whatever caused the initial insult, whether it was the smoking, the diabetes, what have you, family history, it doesn't just affect your leg arteries. It affects all of your arteries. About 25 to 35% of people have at least disease in 2 of these territories: coronary artery disease, cerebrovascular disease, and peripheral artery disease. And a good 9% have overlap of all 3 diseases. Next. In a recent study of commercial Medicare and Medicaid patients over 40 years, in the US, prevalence of PAD was 10.7%. Critical limb ischemia had a prevalence of 1.3%. And critical limb ischemia developed in 11% of people with PAD. The prevalence was higher, as you would expect, in patients with Medicare and Medicaid, most likely secondary to access issues and socioeconomic issues. Next. What is the global impact of PAD? Well, over 200 million people around the world suffer from PAD. And from 2000 to 2010, this number went up by 24%. With the increasing rates of diabetes, obesity, chronic kidney disease, hypertension, I'm sure this number is much, much higher now, period. Next. As we just said, this is a systemic disease. We need to look at the whole patient, not just the toe. A patient with PAD has coronary disease, has cerebrovascular disease. They may not be symptomatic from it, but the disease is there. 1/3 of men and 1/4 of women with coronary artery disease or cerebrovascular disease have PAD. Coronary artery disease of at least one coronary artery has been reported in up to 80% of those with PAD. And about 12 to 25% of patients with PAD have hemodynamically significant carotid artery disease. Next. Well, PAD doesn't always present very typical symptoms of claudication or what we think is the typical presentations. People can be asymptomatic. A good 2/3 of patients remain asymptomatic. It is a progressive condition characterized by arterial stenosis and occlusion in the peripheral bed. The PAD ranges in severity from intermittent claudication to critical limb ischemia. And we hope that we can intervene before they have limiting claudication. That's the time to take care of these patients, not just taking care of their PAD, but taking care of their other comorbidities. Next. Again, not everybody comes in with typical presentation of calf pain. People have musculoskeletal disease. People have spinal stenosis, neuropathy, other musculoskeletal lumbosacral pathology. But we have to be tuned into this problem. If they got the risk factors, smoke and diabetes, had a coronary artery bypass grafting, we need to know that they're at high risk for having peripheral vascular disease, even if they're not symptomatic at this point. It is not that you're going to fix their artery right now because they have no symptoms, but it is something to keep an eye on before they present with critical limb ischemia. Next. What's the easiest way to look at peripheral vascular disease? Is ankle brachial index. It's very easy to do. All you need is a stethoscope and a blood pressure cuff. So anything over 0.9 is normal. And when you get down to the range of 0.4, 0.5, that's when we know you have severe disease. That is indicative usually of multisegmental disease, which can then lead to critical limb ischemia. Next. We cannot, I emphasize, we cannot blow off an abnormal ABI. I just put this study up because it was pretty intriguing to me. This was an osteoporosis study. Women age 65 and older. They all had ABIs. I don't know why, but they did. And I'm glad they did. Because if you look here, when their ABI was normal, the top two lines, when their ABI was over 0.9, normal ABI, at 4 years, almost all of those people were still alive. But if their ABI was less than 0.8, that's this blue line going down, you can see at 4 years, 25% of these people had already died. Again, we can all agree that they didn't die because of a ABI of 0.6. No, again, I emphasize the fact that this is a systemic issue. We cannot just send this patient home and say, oh, your ABI is 0.6, come see me in 2 years. No, we have to look at their coronaries, their cerebrovascular territory, rule out aneurysmal disease, etc., because that's what they die of. Next. Early screening for patients for PAD. This is a very important issue in this disease. One of the earlier talks, we mentioned this, that we as physicians, particularly our primary care physicians, colleagues, they really don't know a whole lot about peripheral vascular disease. And this was outlined in a study that was published in JAMA. And a bunch of physicians were surveyed and given a questionnaire, and the results were just awful. So we need to be in tune about this disease because it is common, it is out there, 200 million people. So if you're over 80, over 50 years old, I'm sorry, current or past smoker, kidney disease, high blood pressure, high cholesterol, all the risk factors that we've already talked about on physical exam, poor hair growth, thickened toenails, pale toes, dependent rubor, all of these things are evidence for significant disease, or at least they prompt you to further study these people. Next. And this is a slide for mainly for the residents. Again, we also have to realize that the disease, we always talk about calf claudication, but not everybody presents with calf claudication, right? It depends on where the disease is. The symptom is always a level below where the occlusion is. So, because SFA is a more common side of disease, yeah, most people then develop calf claudication because the calf is a level below the thigh. But if you have aortoiliac disease, you would expect buttock claudication or thigh claudication, or if it is bilateral, they may just come to you complaining of impotence. So you have to know the anatomy. You have to know where the disease distribution is, because if you know this, somebody else talked about a good history and physical, perhaps Dr. Oye earlier. It is very true in vascular surgery that a good HMP will give you more than 90% of the information you need. You know exactly where the disease is, where the distribution is, and then based on that, then you can do what you need to do. A good HMP still works. Next. What are our treatment options? Well, there are things that we can change and there are things that we cannot change. Your family history is your family history. There's not much you can do with that. But you can stop smoking. You can lower your blood pressure, control your diabetes, lower your LDL cholesterol, have a healthy diet, and regular exercise. There are medications to help you with all of this. There are medications that may help you walk further before having pain. And then if all fails, then we also have surgical intervention. Next. Well, what is critical limb ischemia? As claudication is a situation where the supply of oxygen and blood cannot meet the demand of a territory of muscle, that's claudication. That's when, and it happens when you walk. So the demand is higher than supply with activity. So that's claudication. But critical limb ischemia is when the demand is higher than supply, even at rest. So for me to make this point to the residents, I tell them think about angina and unstable angina, right? Angina is when you get chest pain when you're running around. But unstable angina, you have chest pain even sitting around doing nothing. The annual incidence of this is up to 3,500 per million. The prevalence is 1% of adult population and 10% of adult population who has PAD. And it costs a lot of money to take care of these patients. Next. We have some objective testing to objectively diagnose this. ABIs we already talked about, less than 0.4, 0.5, usually points to multisegmental disease that leads to this problem. Toe pressure less than 50, ankle pressure less than 70, transcutaneous oxygen level less than 50. And we also have to recognize that a subset of patients with diabetes and renal disease are going to have falsely elevated numbers because of medial calcinosis. Next. What the cornerstone of treatment for critical limb ischemia is what? Is to revascularize to relieve ischemic pain, is to heal wounds to preserve a functional limb, to maintain ambulatory status, and to prevent major limb amputation. Those are the cornerstones of treatment. Easily said than done. Every 30 seconds, just think about it, every 30 seconds, a lower limb is lost to diabetes. That means about 3,000 around the world every day. Arterial insufficiency frequently contributes to poor healing in diabetic ulcers. A patient with rest pain or gangrene should be referred immediately to a vascular specialist because delay increases risk of limb loss. Next. This is an amputation heat map of the US. And during this meeting, we have talked about some perhaps sub-Saharan countries, maybe we don't have access to good care or things like that. But I don't think it's just limited to those countries. I mean, look at the Midwest in the US. Look at Texas and upper Midwest. I mean, these are all red states. I don't mean red politically, but red in this amputation heat map. What that means is that there are 6 amputations per 1,000 patients in these areas with diabetes and peripheral artery disease. Still a lot of amputations going on. Next. Well, what is our role as vascular interventionists? Well, we want to drive the left side of this equation up and the right side down. We want to have earlier PAD screening, more PAD and critical limb ischemia therapy, which then should hopefully lead to less amputation. Next. Because, you would think intuitively that, hey, amputation, one-shot deal, you amputate, it doesn't cost a whole lot. And of course, we know administration's always looking at lower cost and cost saving. But look at this. I mean, amputation actually costs more than bypass or endovascular cost because there is loss of productivity and rehab and all of that is involved. So amputation is not the cheapest way to take care of these patients. Next. This is a few years old now, but it is just to drive a point in that angiograms and revascularizations are utterly underutilized prior to amputation. In this study, in this review of Medicare patients only, more than 50% never had an angiogram before undergoing an amputation. I would like to think that these numbers are lower now, and I think they are. But again, in those areas in the south of US and Midwest, rural areas, I don't think they're going to be a lot lower than this, which is unfortunate. Next. And why is that important? Because we know amputation rates decrease as revascularization rates increase. I mean, this just is intuitive, I would think. This is a single center 12-year review. And you can see as your interventions increase, whether it is surgical or endovascular, again, more recent is endovascular as opposed to surgical. But the point is that the amputation rates went from 32% to only 5%. It makes a difference when you do an angiogram, see what you can do with them. I mean, we've had several talks already. We have amazing tools in our toolbox nowadays, whether it's atherectomy and drug-coated balloons and stents and everything that you can name, shockwave therapy now. We have tools to help these patients besides offering them an amputation. Next. Well, then the question comes, should we offer these patients endovascular therapy or surgical therapy? And this is my own opinion, I think the jury is still out in this. And I'm going to show you a couple of slides to tell you that. Because, well, first of all, there is a diverse group of interventionalists. It's not just us vascular surgeons. There are very good interventional cardiologists, interventional radiologists, other people take care of these patients. And the decision-making is affected by patient factors also. What are the comorbidities? What is the conduit availability? What is the disease pattern? And also physician factors. What is their training? The facility, referral patterns, and biases. Next. So the basal trial, the bypass versus angioplasty in severe ischemia of the leg, was sponsored by the UK National Institute for Health Research. It compared efficacy, health-related quality of life, and cost of PTA first versus lower extremity bypass first treatment. 452 patients were enrolled over a 5-year period, and then they were followed for 3 years. Their conclusion was that there was no significant difference in amputation-free survival or overall survival between the two groups. 57% for lower extremity bypass versus 52% for PTA at 2 years. Next, and then the basal 2 trial came up with a different conclusion, and they concluded that an endovascular first strategy is superior to a surgical vein bypass first strategy for patients with chronic limb-threatening ischemia. This conclusion was based on the findings that patients who received endovascular treatment had better amputation-free survival, driven by a lower rate of major amputation and health. Next, and then the best CLI, the best endovascular versus best surgical therapy in patients with critical limb ischemia, yet came up with a different conclusion. This was a prospective, open-label, multi-center, multi-specialty, randomized controlled trial to compare treatment efficacy, functional outcomes, cost effectiveness, and quality of life for 2,100 patients suffering from CLI. Of note is that all of these patients were candidates for either endovascular or surgical bypass. This was conducted in 130 sites around the world. Next. The enrollment, completed in October 2019, and the follow-up was 24 months. The conclusion was for patients who are candidates for both open surgery and endovascular therapy, surgical bypass was more effective in preventing major adverse limb events, reducing the need for reintervention, and decreasing amputation when, and this is important, when a suitable saphenous vein was available, a single segment varicose vein of good quality. So, like I said, in my opinion, we still don't know. In my practice, and this is just my practice, I look at the whole patient. I see what their disease pattern is, what they need. Do they need a gangrenous toe to heal, or do they need to just have relief of their pain? What are their comorbidities? Look at all of that. Look at the whole patient before you decide what would be the best option for them. Next. These recommendations make a difference because some of the numbers here. This is a busy slide, but I'm just going to mention a couple of things here. When somebody has an endovascular procedure, 65% of those people go home. After bypass, 55% go home. But if they have an amputation, only up to 24% end up going home. The rest have to go to nursing home or rehab facility. In-hospital mortality is higher for amputation. How about ambulation? This is a major issue that causes a lot of other issues, psychiatric issues, and other, loss of wages, everything else. After endovascular or surgical bypass, 81% of patients are walking after 2 years, 88% living independently, whereas after amputation, up to 80% cannot walk. And again, the mortality is much higher after amputation at 2 years as opposed to either of the other interventions. And not to mention after amputation, there is a high rate of depression as well as contralateral limb issues and wage losses, etc. Next. And we know there is a lengthy healing process after amputation. At 100 days, 45% of BKs and 24% of AKs had not healed. Quality of life is reduced, severe physical impairment in ambulation, body care, movement and mobility. Chronic pain is 95%, phantom limb pain in up to 80%, residual limb pain in up to 74%, and back pain in almost 62%. And there is a high problem with skin care as well. Next. So having said all of that, we really need to concentrate on how we are going to reduce the numbers of amputation all around the world. And this cannot be achieved by one person. It cannot just be the vascular interventionist. You need a whole team to do this, to be successful. For a successful critical limb ischemia team, you need the vascular interventionist, podiatrist, vascular medicine, endocrinologist, infectious disease, rehab, cardiologist, nephrologist, orthopedics, prosthetist, wound care nurses, plastics, and I can probably add a few more to that. But you get the point. This is not something that we can do by ourselves. We need help from our other colleagues. Next. Just a quick word in PAD in women. It is often under-recognized and untreated according to American Heart Association. Healthcare providers should proactively increase awareness of and test women at risk of PAD. Women with peripheral artery disease or PAD are 2 to 3 times more likely to have a stroke or heart attack than those without it. Next. And this is also another slide that sort of blew my mind away, is how aware of are our patients about peripheral artery disease. Not only our primary care physicians are not aware, but the patients are not aware either. Look at this. I mean, 3/4 of patients knew more about stroke than PAD. People even knew more about ALS and multiple sclerosis than they knew about PAD. Only about 1/4 of people knew very or somewhat familiarity with peripheral artery disease. We need to do better here. Next. And all of that is really up to every one of us. We, as the physicians, have to champion this. We have to be in the front line, and we have to come up with whatever we need to, whether it's protocols, guidelines, whatever needs to be done to early screen these people, identify the individuals who are at risk of this condition. And then we can sell that to our hospital administration, and then distribute in the community with the primary care physician. It is a teamwork truly in its essence that's going to take care of this problem. I believe that's my last slide. Next. Thank you. I'll be happy to answer any questions.
Thank you, Dr. Gashti.
You're welcome.
Dr. Oye.
I think Dr. Oye is speechless.
Yeah, you left him speechless with such a great presentation.
Can you hear me?
I can hear you.
Jay, can you hear me?
Yeah.
Can you hear me? Hello?
Yeah, I can hear you.
Can you hear me? Yeah, very well. Thank you. Thank you, Dr. Ashley. I appreciate the very deep and insightful talk. And again, concentrating on all the prior speakers. You've put it together. Again, it's important for PAD for our population. It's amazing. And your last slide or a few slides that made the point. PAD awareness is so low, and that's the reason why we're doing this, taking this initiative today in Bayelsa, in the southern part of Nigeria, to raise the awareness. The amputation index for patients here, like you mentioned, and Dr. Das mentioned earlier today, is extremely high. 65 to 80% of patients seeing a first treatment option is primary amputation. And that's not good enough in 2025. So again, thank you so much for the opportunity to help us spread the word on PAD. And we look forward to you helping us again in 2026 and 2029 when we get the 27, when we get the 9th and 10th versions of the conference. And we hope that then the awareness for PAD will be a little more elevated in the society here. Again, the take-home message is when it comes to PAD, delay is dangerous. That's an African term or a phrase that they use here. So they should take that to heart. Delay is dangerous. If you delay, you'll lose your leg. If you lose your leg, you get depressed. You get depressed, you will die. You know, so it's like delay is dangerous. So thank you so much again, Dr. Gash. They appreciate it. Any more questions for Doctor?
You're welcome. Thank you.
Thank you, Doc.
Thank you.
Enjoy your study from Florida.
Okay.
Thank you, Dr. Gashti.
Thank you. Have a good day. I'll see you, I guess, in New Orleans, right?
Yeah, I'll see you next year.
New Orleans.
Yeah.
New Orleans next year, September. Thank you. It's like
Yeah, I'll see you
September
then.
30. Thank you.
Yeah, see you then. Bye.
Thank you.
Our next speaker is
Again,
Given
what's the next speaker?
Given Edim.
You've seen a lot of prominent speakers from Florida, from Saudi Arabia, from London. It's a concept we're trying to let us know it's a problem. And if you know you have a problem, you got okay. Yeah. So if you have okay, thank you, buddy. So if you know you have a problem, you say a problem shared is a problem half solved, right? So when you have a problem, you have to share it. You can't have a major vascular problem, don't tell your family members or they don't tell you, so you can be proactive. And when you now bring it to your attention,
We seem we've lost Dr. Oye. I'll go ahead and share the slides for Given's presentation. Our next speaker is Given Edim. She's a fourth-year medical student who will be speaking on peripheral artery disease. given. The floor is yours.
Okay, can you hear me? Can everybody hear me?
Yeah, I can hear you.
Hello? Okay. Okay, I want to say thank you again to Dr. Gasti. I kind of feel like he's done my entire presentation. It was so good. So I want to say thank you, doctor. You did a really great job, mostly with the explanation of ABI in relation to survival and the epidemiology. It was so good. It has really brought a lot of understanding to me.
Thank you. Thank you.
Thank you, sir. Okay, yeah, next slide, please. I'm going to be talking about peripheral artery disease, and I'll go straight to introduction. I think I'm going to be skipping some slides because Dr. Gasti has done justice to a lot of slides I have on here. Okay, what is PAD? It's a peripheral artery disease. Just give me a second, please. Okay.
We can see you. We can see your image.
Okay, yeah, I'm gonna go ahead with it. Okay, it is peripheral artery disease. Okay, peripheral artery disease is a common circulatory problem in which narrowed arteries reduce blood flow to the limbs, typically the legs. It is also a form of atherosclerosis, which is hardening of the arteries due to plaque buildup. So in PAD, the limbs, especially the legs, don't receive enough blood flow to keep up with demand. This can lead to painful working, ulcers, and in severe cases, amputation. Next slide, please. Briefly, I'll talk about the epidemiology. It affects over 200 million people worldwide, 8 to 12 million Americans, or roughly 10% of the entire population aged 40 and above. Risk increases with age, especially over 50, and it's strongly associated with diabetes and smoking. Next slide. Causes and risk factors. The primary cause of PAD is atherosclerosis, which is, like I said previously, buildup of plaques in artery walls, causing narrowing on blockage of blood flow. Secondary causes include modifiable. We have modifiable and non-modifiable factors. The modifiable factors include smoking, diabetes, high blood pressure, high cholesterol, obesity, physical inactivity. So if you're not an active person, some persons go to work and they sit all through the day, it could cause buildup of plaques. Non-modifiable factors include age, family history of cardiovascular disease, male gender. Women catch up post-menopause, most especially. Race/ethnicity, we have it most in African Americans. So the risk is very high in African American population. Symptoms, go to the next slide, please. We have the symptoms. It can be asymptomatic in early stages. That's why most people don't know what they have. They kind of go to the hospital at the end stages where it straight up leads to amputation. Most common symptom includes claudication. You get pain or cramping in legs during activity, usually the calf, and it's relieved by rest. Other symptoms are numbness or weakness in the legs. Cold feet or legs, especially one colder than the other. So when you get the symptom, you notice one of your legs is colder than the other. When you feel it, it's alarming. You should go to the hospital to get it checked out. So we have weak or absent pulse in the feet. We have shiny skin, slow growing toenails or thickened toenails. We have sores or wounds on the feet that don't heal. Erectile dysfunction. Dr. Gasti said that if it is in the bilateral arteries, the first sign could be erectile dysfunction in men. So you come and say, I don't get erections, and it results to sometimes they have PAD without knowing. Next slide, please. So the diagnosis, ABI compares to diagnose PAD. The first thing is to do ankle brachial index, which is ABI. It compares blood pressure in ankle versus arm. ABI less than 0.9 suggests PAD. Normal PAD is between 1.0 and 1.4. and you use the Doppler ultrasound. You can also use treadmill, do the treadmill test, monitor symptoms and ABI before and after exercise. You can also do angiography, imaging to show or to view blood flow using contrast dye. We can also do blood tests to check for cholesterol, blood sugar, and kidney function. There are different stages and classifications of PAD. The first one is usually asymptomatic. And the second, we have 2A, which is mild claudication. It's not bothersome. Sometimes people just live with it and they don't go to the hospital for this because it's mild. Then we have the moderate to severe claudication. Then from there, you get pain from resting. And then this leads to ulcers or gangrene. You can also use the Rutherford classification. I didn't put it in here. This is a staging method based on the severity of symptoms and tissue damage, ranging from 0, which is asymptomatic, to 6, which is major tissue loss. Treatment. The first way to treat PAD is lifestyle changes. You have to quit smoking. It's critical to stop disease progression. You can do supervised exercise, walking program, 30 to 60 minutes, 3 to 5 times per week, which improves symptoms. And then diet. Diet is very important. So what you put in your body can lead to you having PAD. So low in saturated fats and refined sugars. You can also do weight loss, which helps with blood pressure control, cholesterol, and diabetes. Then there are some medications you can take to called PAD. The first one is antiplatelets. You have aspirin, clopidogrel. This prevents blood clots in the blood vessels. The second one is statins, like atorvastatin, rosuvastatin. This lowers cholesterol and stabilizes plaques. ACE inhibitors, this controls blood pressure. Cilostazol improves walking distance. If you're a heart failure patient, it's not good for you. Then pentoxifylline is less effective than cilostazol, but it's rarely used nowadays. So the third procedure is surgery. Now you can do angioplasty plus stenting. A balloon is inflated to open the artery, often with a stent placed, minimally invasive. Atherectomy, this removes plaque mechanically. Then you can do a bypass surgery. This uses grafts to enroute blood flow around blocked artery for severe blockages. And then the last one is amputation. This is what we're trying to avoid. In end-stage cases with severe tissue death, you can, like when it's gangrenous, this can lead to amputation because you cannot have blood flow in that limb anymore. So we have some complications like critical limb ischemia, which Dr. Gashti did justice to, then amputation, heart attack, or stroke. PAD is a systemic atherosclerotic disease. You also have poor wound healing and decreased quality of life. I'm going to be presenting this case that was done in Raleigh General Hospital, led by Dr. Oye. I was the assistant, and we had Tammy Canada also assisting with Sandra Clay, who is an MP there. So this patient is a 61-year-old female who presented with pain and pulselessness on the left foot. She was allergic to aspirin, past medical history of hypertension, COPD, brain aneurysms, cardiovascular accident, history of breast cancer with left breast mastectomy, peripheral vascular disease, rheumatoid arthritis, lupus, and left foot drop. The past surgical history include left breast mastectomy, brain aneurysm, microdiscectomy of lumbar spine, right knee surgery, cholecystectomy, left arm surgery, right total hip arthroplasty, bilateral tubal ligation, and hernia repair. We did a physical exams, and S1 and S2 heart sounds were normal. The lungs were clear on auscultation. There were no carotid broods. There was negative DP/PT on the pulses on the left leg, but it was on the right leg. So that was the leg we operated upon. Family history includes mother who had renal cancer, hypertension, diabetes and renal disease, social history. She has smoked half a pack of cigarette every day for 39 years. She denies alcohol or illicit drug use, and all systems were reviewed. And other systems were negative or non-contributory. So let's go over to the postoperative diagnosis. The first one was peripheral artery disease, which is my topic. The second one was left femoral popliteal artery occlusion. The third one was pain in the left limb. Anesthesia was given, which was general. We took some specimen out from the it was a popliteal plaque. There was no complications and blood loss was estimated at 250 ml. Then operative procedure. Next slide. Okay, the first one was left popliteal artery exposure with a retrograde angioplasty of left fem-pop artery with a 5 millimeter by 150 millimeter DC balloon and intravascular lithotripsy with 5 by 80 balloon. The second one was left popliteal approach anterograde angioplasty below knee popliteal artery and posterior tibial artery, aortoiliac arteriogram and left fem-pop arteriogram with runoff. The fourth one was intravascular lithotripsy of the left popliteal and tibial arteries with 4 millimeter by 80 millimeter balloon. Operative findings, the slide before that, sorry. Okay, the first one was aortogram revealed aneurysmal dilation of the infrarenal aorta, left fem-pop occlusion, left below knee popliteal occlusion involving the proximal posterior tibial artery. So the next slide just shows the aneurysm that was found on the aorta. Can you go to the next one, please? Yeah, these are just photos trying to show you how we were trying to had the occlusion of the vessel. This is the wire. You see how it was nicked because of the occlusion. Next slide, please. Next slide, please. Okay, I'll just go straight to giving you.
You can see the wire going up.
Hello?
That artery is 100% clogged up. So
yes, so
ahead.
that's the
I'm just
nicking
telling
of
the audience here. That artery is 100% clogged up.
Okay. Okay, yeah, it was
Very
so
calcified
we
artery.
couldn't pass
You can
pass
see
the
the
wire
calcium
through. Is he saying something? Yeah, you saying something?
Next one.
Next slide, please. Okay. I'll just give you the view of what we did. The slide before was showing you how occluded the vessel was. So we had to cannulate it with a micro needle, the micro guide wire and sheet. Then they were introduced upside to a 4 French sheet, then proceeded to place a Prolene glide wire and pass the 0.035 universal flush catheter into the abdominal aorta. The aortogram demonstrated patency of the aorta with an aneurysmal dilation. Then balloon of the radial artery was patent, also with the bilateral iliac arteries. Then a runoff was done from the distal aorta to demonstrate left common femoral artery that was patent, likewise the deep femoral artery. But the superficial femoral artery had flush occlusion for the entire length with reconstitution at the Hunter's canal. So this is just showing you, I picked a few slides that showed the progress of the surgery after the occlusion was removed. We're able to pass a glide wire through, so you can see that it's patent now. Can you go to the next slide, please? This was below the knee. You see that there was a lot of collaterals because of the occlusion, the picture on the left. And then, can you go to the next slide, please? Yeah, so below the knee demonstrated stenosis and occlusion of the popliteal artery. So we proceeded to make a popliteal incision because of the flush occlusion, like I earlier said. So a 6 cm incision was made within the border of the left thigh through the skin into the proximal distal portion of the popliteal artery. This was achieved with a celastic fistula, and of course, heparin was given just to check for coagulation. Can you go to the next slide, please? So it looks a lot better. This is below the knee after we were able to go through the artery. Next slide, please. Left popliteal arteriogram on the French shade was placed. Then with the help of an advantage guide wire, we were able to go retrograde to cross the occluded segment of the femur artery and advance the wire into the iliac artery. Then we treated the entire segment of the femur with a superficial femoral artery distally. Next slide, please. Yeah, this is how it looks now. It was totally occluded, but we're able to pass the wire and it looks a lot better than it was previously. Next slide. Following the treatment, a completion arteriogram was done and we had satisfactory flow with patent profunda and SFA with improved flow in both. A position of the arterial wall was noted without dissection, so we didn't have any complication of dissection. Following this, we performed anterior grade cannulation of the popliteal artery below the knee, with wire manipulated into the posterior tibial artery, but the segment was completely occluded with collaterals noted. That's what I showed you in the previous slide. I think it was mixed up. Next slide, please. Okay, this is another one showing the collaterals. Next slide, please. So post-completion flow was noted to be much improved. The area of occlusion was reversed, and we then proceeded to perform an endarterectomy of the popliteal artery. The popliteal artery was repaired primarily with a 5-0 Prolene suture in running manner with good repair. Then the tissue was closed again with 5-0 Prolene suture, so we had to sew it back together, suture it together. 2.0 cm incision was made, and Jackson Pratt drawing was inserted, secured with 2 0 vicryl suture in a running manner. For the deep subcutaneous tissue, muscle and skin were sutured with approximately 3-0 Prolene sutures, and staples were applied. Next slide, please. So this is a photo of the endarterectomy we did. We took out some plaques, and there was viability of the vessel afterwards. Next slide, please. Okay, can you put this video? This was just to show the runoff after the procedures. She had good blood supply to the limbs afterwards, and there were pulses also. Okay, thank you. Go to the next slide. Yeah, so pulses were measured with a Doppler post-surgery, and where they were present, no complications were encountered. The patient was transferred to recovery in a satisfactory condition. So to prevent PAD, I just put a few factors here that you can quit smoking, control diabetes or blood pressure and cholesterol. That's if you have high blood pressure or you're diabetic. You can exercise regularly, eat a healthy diet, routine follow-up with a healthcare provider. So this can help in the prevention of peripheral artery disease. Next slide, please. Yeah, that's the end of my presentation. If you have any questions, you can ask.
Hey, Given, this is Shadi from West Virginia, close to you.
Oh, okay. Hi.
Thank you so much for the presentation. Really great case. I just want to echo something that you mentioned about the lifestyle changing and the modifications. You mentioned the fastest way. I think it's probably the slowest way, which is very important to tell our patients. It takes time for the effect of the social changes and how to eat and how to exercise. But on the long term is probably the most effective way of keeping these people legs. So I tell my patient when they come to us, like, you want to keep me legs, you have to change what you've done for 50, 60 years. If you don't want to keep your legs, I can help you put a stents and balloon him. but you probably end up losing your legs. So if you want to keep your legs, you have to change your life. It's not going to be a short-term thing. It's going to be something you change for the rest of your life, not overnight, not just one pill that, unfortunately, it's everybody likes the fast food now. So it's not a fast food. It's a really slow cooking thing.
Thank you so much, doctor.
Thank you.
Any other question or observations?
Something.
Okay, I think this will be the end. Thank you. Thank you, everyone.
All right, thank you, Given. Our next speaker is a distinguished vascular surgeon based in Charleston, West Virginia. Ladies and gentlemen, it is my honor to introduce Dr. Shadi Abu Halimah. He's a fellow of the American College of Surgeons and currently serves as program director of the Vascular Surgery Integrated Residency and Fellowship Program at Charleston Area Medical Center. Dr. Abu Halimah earned his medical degree from the University of Jordan, completed surgery residency at West Virginia University, and his vascular fellowship at the University of North Carolina. He brings over 20 years of experience in both general and vascular surgery with expert knowledge in peripheral vascular disease, carotid disease, endovascular and open procedures, and complex aortic pathology. Today, he will present on endoleak, offering deep clinical insight drawn from his robust surgical practice and leadership in vascular education. Please join me in welcoming Dr. Shadi Abu Halimah.
Thank you so much for the invitation, and I really appreciate my brother, Dr. Oye, invite me again. I'm really honored to join you guys again this year. I'm going to share my slides. Go back to the presentation. I hope you guys can see that.
Yeah, we can see it now.
So it's a topic that I hope it's relevant to a lot of people as we evolve and push more toward endovascular intervention for aneurysms. In the last probably 20, 25 years, since I was a resident, I came here and probably half of the cases were done open, half was endo, and now switching to almost like, I would say 90%, if not more, endovascular. And the patient, they have to understand that this is not the gallbladder that we take care of it and they can go home and they don't have to come back. It is a big deal because endoleaks happens and these endoleaks need to be managed. And stent graft, they're not stitched in, the aneurysm's still there, and a lot of things could need to be done. I'm not saying it's always happened, but we cannot just let the patient go home. Especially, we do still operate in older population, but we do offer procedures for younger people. And when we do that for younger people, which I tend to push more toward open surgery for more durability, is to do more definitive repair, more finister graft, more branch graft for these patients, because I do believe that they will degenerate. Now, this type 5 endoleak, it's kind of a topic that I was asked a few times to talk about, and it's pretty interesting as a surgeon that does a lot of endovascular. I have no disclosures. Just quick thing going through type endoleaks. After aneurysm repair, we have called type 1 endoleak, 2, 3, 4, and 5. I'm going to mix them together back and forth because I don't see any literature that don't mix them together, but I'll try to define both of them. 1 endoleak, it's the most dangerous, is where you have no adequate seal, either proximally or distally. Or sometimes they add 1C as a called iliac plug occluder, or they could put it as 2C. So it's kind of two different things. But when you have no seals on proximal distal, they have type 1 leak that typically need to be repaired. You cannot leave it there. Type 2 leak is the most common, where you have a endoleak going backward into the aneurysm through small branches, including the IMA lumbar, typically small renal, hypogastric arteries sometimes. Type 3 leak, where there's a tear in the fabric or there's a separation between stents, or when you do a branch graft or fenestrated, there's separation between the stents that you put in. So either disconnection or there's a fabric tear, which we see more often in the long term. So remember that the fabric tear that we see in there's some stents that we see more often, like the AFX, being notorious, especially the first and second generation. The third one is less. But believe me, even polyester grafts like Medtronic or Cook, they can have tears in the long term. Type 5 and type 4 airways, there is no really endoleak that you can see, but the aneurysm is getting bigger. The type 4 we talk is probably from porosity, usually within 30 days. When you do an angiogram final image after deploying graft, you see this flush of contrast, but you can't see a tear point, and you come back in a month and it's gone. And the endoleak type 5 is truly defined by there's a sac expansion, but I don't see really blood in the sac. So that's another picture of type 1 endoleak. The endoleak from the top and the bottom. Type 2 is the backward filling from the IMA or lumbar. Type 3 a tear. Type 4 porosity, and type 5 is just an expansion. So I'm going to just have a poll. I mean, you would give this presentation. When you have a type 5 endoleak, you have a patient that have endograft, and the aneurysm, you put the graft, it's 5 centimeters, or let's say 6 centimeter aneurysm. It shrunk down to 4 centimeters, but after 15 years, the aneurysm come back and it's 5, and now it's 6 or even 7. Patient has some mild abdominal pain, but there's no endoleak. You don't see endoleak. What would you do for these? This is a by defined type 5 endoleak. Would you take him surgery, explant the graft, which is a big morbid procedure, has a higher perioperative morbidity and mortality? Would you put more stents? Would you do just watch them? There's a lot of dilemma. I tell people in these days they push more for endovascular. Again, the algorithm for endoleak repair, again, we talk about 1 or 2 or 3. 1 and 3, they just tend to be endovascular repair. Typically put a cuffs up top proximally, coil embolize, hypo, extend, maybe do a fenestrated graft with type 1 endoleak. Or of course, some people do open repair, convert them. With type 2 endoleak, unless you see a sac expansion, most of people just watch them. And type 5, that's what we're just like, I don't know what to do. Looking at this picture, type 4 endoleak, I'm going to mix it with 5 because there's a porosity of graft, maybe through the suture line. These grafts are stitched to a stent, or there's again, we see a plush through the graft. This typically more happen with the first generation of polyester, PTFE graft, but we see with thin graft, more companies are trying to make thin wall graft so they can actually put it through a smaller sheets. And we see this type 4 endoleak that will disappear with time. Again, type 4 could be just, again, typically it's from polyester graft first generation, but the current generation with a really thin graft resolved typically within 24 hours, but within a month it will be gone. Shouldn't see any contrast in the CAT scan. But on the initial image, after you finish deploying the graft, it can obscure type 1 or type 3. So you end up injecting more contrast. It's kind of annoying when you see this plush and it's like, well, let me pull the pigtail, inject more contrast just to make sure I'm not leaving type 1 leak. So an endoleak of undefined origin, that's what we call type 5 endoleak, or some people use the word endotension. So it's a sac expansion without demonstrative leak of any imaging tool. We can get any imaging we want to do. You can do a CT scan, you can do a dynamic CT scan, you can do delayed images on the CAT scan, which typically we have to do as 3-phase imaging. You can do contrast duplex ultrasound, not just conventional. You can do a conventional angiogram with cone beam CT scan, and you still cannot see a leak. You see just a big sac, and it's getting bigger. And again, with no sepsis and no inflammatory markers, because one of the reasons for aneurysm to expand is infected graft. So if the graft gets infected or the aneurysm become mycotic, you will see a big leak. And usually this patient come in, they look very sick. Some of them not that septic. Some of them will be a low indurant infection, but they look really sick. They have this long abdominal pain and a lot of back pain. They don't have to be really in septic shock to be infected, but again, no sepsis, no inflammatory markers. Sac enlargement, typically if you biopsy these, you see like a protein-rich exudate. You don't see blood, you see exudate in common these. Again, it's typically related to transfemoral fluid the leakage. And when you do an open repair for these, you see this whitish, it looks like pus. You think it's really pus, but it's really fluid and exudate, whitish plasma, looks like plasma, really inside the aortic sac. So type 5 endoleak, it's really poorly understood. What cause and factors? There's multiple theories. Low flow leak, there's type 2 leak, that's from proliferation of vasa vasorum, because it's defined when they do CAT scan for these patients, you see a lot of enhancement in the wall of the aneurysm, but you don't see leakage inside the aneurysm. So they said maybe it's just a small leak that you don't see on this CAT scan. Or there's hyperfibrinolysis, so you have a clot that form, but then the inflammation just keep going on and going on, and that's why we create a seroma or hygroma. A pressure transmitted through the graft, so some of the especially thin wall graft or the non-supported graft, you can have it transmitted to the wall, and that causes the aneurysm to keep expanding. The last one is really the incomplete seal in the landing zone. So people that put stent graft against thrombus and say, well, it will seal, especially circumferential thick thrombus, anything that's more than, I would say, 4 or 5 millimeters, circumferential, distally approximately is like, well, I don't see endoleak. I know, but there's a transmission of sac. And with time, again, this incomplete seal can create more degeneration of the necks. Again, semi-porous graft with the older generation of PTFE or the new one. Again, in public, I would just ask whoever has any experience. I want to ask Dr. Oye because he's my brother here sitting. Have you deployed one of these before, Dr. Oye, or anybody? These are sensors that they came up with like almost 20 years ago, I'd say, and they last for a few years, maybe for 5 years, like till 2005, 2006. These are different three generations of sensors. They were deployed. They were actually came up to deploy behind the stent graft, and it just will tell us, is there any pressurized on the sac or not? So they're intersac pressure monitors. They're not available in the market anymore because the usability of them is gone. More than 90% of the pressure monitoring, they're pretty accurate. They will tell you there's a pressure. There's like the moment you deploy them, it's like, oh, the pressure dropped down to 50. But unfortunately, did not show in any of their studies. There's the one in the A is the most common one. It was deployed in the sac itself. The B1 was actually deployed on the wall of the graft, one of the wall of the graft, but they did not correlate with endoleak. So you could have endoleak, but you don't see a pressure change, or you can see a pressure increase, but I don't see a good endoleak. So they will tell you there's a pressurized sac, but they will not. They still you need to do a CAT scan, which is probably the gold standard follow-up for a patient with endoleak. So it did not prevent us from doing CT scans. I did not correlate with sac enlargement. So patient could be having a low pressure, but they have sac enlargement, or they could be really high pressure, 50s, 60s, and there's no sac enlargement. So they pull it off the market. It's pretty expensive. Again, let's go back to type 5. Again, you have a patient that have a sac enlargement. Endoleak is a deceiving word. It's endotension, you confuse it. So, but I don't see a leak. So what to do for these? You can go for a lot of various options. You can do called endovascular reinforcement, and I'll give you options now. I just put one of them, which is relining the stent graft and cuffs. Open repair of endovascular failure. You can just again, it's most definitive. Probably do an open repair because you got to know with aneurysm. Some people try to do aspiration. They stick needles and put drains in them. They can do laparoscopic aspiration, and they can actually fenestrate the aneurysm. They make holes in it so it will leak into the retroperitoneum and will decompress the sac. Or some of them will actually do some open repair, and instead of removing the graft, they just do site plication, which we do sometimes for some of these patients. We do lumbar embolization or lumbar ligation, or try to tighten this. We just cut part of the sac and we plicate it around the sac. But unfortunately, the last two did not show a really good durability with type 5 endoleak. They end up with a lot of enlargement in the future. So what endo options we have? I have a leak. Again, I think it's either porosity of the graft, there's a hole in the graft, there's no neck. So what we do, the most common option people do now is they just call the go rep, and it's like, hey, let's put a cuff in the top part of the graft, because most of these grafts are modular, they're short body graft. They put a cuff or two, and they put 2 iliac limbs inside them. Again, it's done for mainly short body graft, which is the most common graft you use. And what's the problem with this? And I can go to the image here before. If you think about putting a 36 graft, you have a 36, say, endurance graft before. You put another 36 cuff inside it. And the gore limbs, both of them are all gore limbs. The proximal part of them, they are the biggest proximal limbs. They are 16. millimeters. So you have two 16-millimeter limbs inside a 36 diameter graft. If you think about it, you create a gutter already. It's like a snorkeling. So you have a gutter that will leak inside there. So you don't have a really incomplete seal. Now, can you have some seal? I think it's okay. Some patient will like, you buy them another year or two, but it's not really a definitive option. Better graft, you can use the Altura graft, which is not available, unfortunately, in the United States. There's a picture there. You can see it in this image here. It has two stents beside each other again, and they are used for aneurysms from the beginning. Or you can use Nelex, which is not available. It's really Endoseal, and it's gone now. It's a really two big stents. Both of them are like, I believe it's 16, and they're deploying one here. They were all in Europe, and they were on trial in the United States, and they got pulled off because of the leakage in the future. So these will seal the neck and seal all the stent, but it's really not durable here. So again, putting kissing stents and cuff will actually end up with gutter leak. Can you put a regular stent from the beginning? Yes. If the graft is completely migrated, you can try to put another graft inside it. But think about it, there's no place to put a stent from the beginning without covering a renal artery or the SMA. So that's where comes the last two options, which is custom-made graft with inverted limbs, along with some fenestrated graft, which makes things to deal with this expanded aneurysm more difficult. So you can do, again, fenestrated graft, which is not durable everybody, or you can do PMEG or physician-modified graft. We can line up the whole thing from the beginning. When you do open repair, typically you can go in, if there's a stent above it, this is, again, it's an endoleak that we don't know what's going on. You can leave these stents at the renal level, leave a small cuff of it, and just do an open repair. You can leave even a couple of stents and just wrap them up. You can leave, very typical on B image. This is a common that I do myself. When these iliac limbs are sealed completely and they're not getting bigger, I actually leave most of the iliac limbs and I just suture my bifurcated graft to the iliac bifurcation. Or you can do, as the last image here, you can actually do a kind of hybrid if there's a lot of inflammation in the bottom of the graft. This is some of the explanted graft. You open up the sac, you see there's no endoleak, but you see this whitish, yellowish material that's around the sac. There is a technique we call double condom technique. I don't know who created this, but where they open the aneurysm, they found that, again, the graft is just sitting there. He will wrap it with a piece of Dacron, and in this technique, he didn't have to clamp the aorta. He just wrapped the endograft with a piece of Dacron, and this will be so it doesn't leak anymore and probably contain it. I don't think I would do it unless the patient is very, very sick and you don't want to do any clamping above the. So in our experience, what happened with these when we do surveillance with these patients, what we find is really these patients that have type 5 endoleak is, in the long term, they have really no good seal, and there's a pretty bad thrombus at the neck. The aneurysm actually, with time, if you just keep watching them, some people say, well, I'm just watching, it's 6 centimeters. They come back next year, 7 centimeters. If you think about the aneurysm keep expanding, and what happened, you lose these necks. You lose even the iliac seal zone. So you lose a lot of seals. So it was a sealed at the beginning, but now there's no seal because the aneurysm keep expanding, and the neck degenerate. Again, patient has a prior endo repair, typically has type 2 endoleak. So they are really persistent endoleak. You open the sac, you don't see a leak, but the moment you open the sac, you see all the huge lumbers just pumping back. So it is something that we see with these when we convert them to open repair. There's an endoleak, unfortunately, with the imaging that we have, maybe because it's so pressurized, we don't see that endoleak. Or what we see actually now with the graft has been sitting there for 20 years, especially even polyester graft, the sutures are pulling through the stent, okay, especially at the crotches of the stents, especially when let's say the cook, when it bifurcates below before the bifurcation, that area has a lot of tension in that area. We found on imaging, and that really pulls off the polyester, and it creates tears. And we learned that from the endoleak that we saw with AFX. You see a really nice stent sitting there, but you don't see a leak. And when you open them up, or you pass a wire, the wire just goes through the stent. So there is type 3B endoleak, which is a tear in the fabric that we don't realize it's there on ultrasound or even the CAT scan, but it's there, and it's causing the endotension and the expansion of the aneurysms. Or again, hygromas, there is no infection. So can we do called surveillance for these patients? If the sac keep enlarging, I think it's a bad idea. They can rupture these patients, and when they rupture, it's very morbid, cause a lot of inflammation. They come almost in a picture of septic shock. If you keep watching this, I promise you end up with more complex aortic aneurysm. Instead of dealing with a juxtarenal aneurysm, you end up with maybe type 4 thoracoabdominal aneurysm. And with the expansion, the stents will come from each other and we'll end up with more component separation. I'm not going to go through this. It's a really busy slide. This is kind of algorithm what you do. So you have again, what causes this? You have to think about this. Again, is there a layered thrombus? You put a stent against the wall neck. Is there an endoleak that I don't see? Is there an infection in the graft that I don't see? Get some cultures, get some maybe PET scan, the best way to deal with an infection or diagnose infection. Some of the grafts, really old generation, could be a porosity of the graft. It could be really a thrombus at the origin of the lumbars or mesenteric arteries that it's back leaking, but I don't see it very well. So what we recommend for these patients? You see an endoleak that is just, I don't see an endoleak, but I see this site expansion. You cannot just ignore this. You cannot tell the patient, hey, good luck, be fine. We have to follow up this CAT scan. I do all the modalities, CT scan, dynamic CT scan, do delayed images, do contrast duplex ultrasound. We do conventional angiogram to make sure there's no 1 or 3 leak that we don't see. If there's the persistence of type 2 endoleak, we keep following with CT scan. Ultrasound, I don't think it's a really good idea for whenever there's a leak, because you will lose that leak, that seal zone, and you don't realize it on the ultrasound. And again, if there's no endoleak and there's increased size, if the patient is symptomatic, open repair, unless there's, again, loss of seal zone, and you can do an endo option is an option. But again, if they're asymptomatic patients and they're getting bigger, you can try endo first. That's probably the only option. I typically do a fenestrator graft to reline the whole things. But if patients come with symptomatic and you don't see a leak and they're having abdominal pain, the aneurysm now is 7 centimeters, I typically take them to the OR and just exclude the whole thing. If there's rapid expansion, you have to rule out infection, but typically you end up with open conversion. And of course, with the rupture, there's an open conversion. Why open repair is better choice than endo option? Because again, we see a lot of hidden type 1 and 3 endoleaks. There's expansion leads to loss of seal zone. So if you just put another fenestrator graft or put another cuffs, you give them another year, they will come back and you have no seal zone. You convert again an infarenal aneurysm or a juxtarenal aneurysm to a type 4 thoracoabdominal, make it more difficult, and typically older patients. Again, typically seen with late aneurysm, they're like 8 centimeters and 10 centimeters, which we know that endo is not as durable as open repair with these big aneurysms. Can see again type 2 endoleak, a lot of these patients, which is more definitive repair when do open repair. The patient that really worry me is number 1, COPD patient on home oxygen. These patients, they degenerate, they rupture really easy. Patient that takes chronic high dose steroids, they keep degenerating, they're not going to stop degenerating. And the last one is more of observation that there's some studies that shows this, they do worse, but they're DOACs, people on Eliquis, Xarelto, all this newer anticoagulant. If they have type 2 endoleak, or if you don't see them, we see more expansion and more persistent leaks that will lead to expansion. So these are patients that you just have to worry and watch them. So again, question again, if you have type 5 endoleak, a big expanding aneurysm, would you still do open or endo? I'm not sure what's the option. For me, it's open repair. Thank you so much, guys.
Thank you, Dr. Shadi. Is Dr. Ori there?
Hi there. Hi there.
Hi.
Is dead. Dr. Shadi. Dr. Shadi. Hello, how are you?
Herb, how are you, man?
Thank you very much. Thank you very much, my brother. You doing all right?
I'm doing good. Thank you so much for inviting me. I appreciate that, buddy.
Much appreciated. Thank you. Thanks for the talk. We appreciate you always helping us out.
Anytime,
Interesting talk.
anytime.
one of the problems we have in Nigeria is there's a lot of aneurysm surgeries to be done in Nigeria. Unfortunately, the technology in terms of endovascular devices are not very common. The only company that makes endovascular devices is Medtronic. The market is wide open. So, and when Medtronic is actually relatively more receptive than most other companies that have approached in terms of trying to bring the technology to save people with AAA scare. So again, we have to work on that, and we just need to keep working on that to see if we can improve the technology to make it more available, because a lot of younger people here have aneurysms. I'm talking 39 with 12 cm aneurysms, you know?
Wow.
12 cm aneurysms, yeah. 39 thoracoabdominal aneurysms left and right. So
Do you tend you guys to do open repair for these, or you didn't do endo option? Because I think for younger patients, open is probably the best way. Because 39-year-old to have a 12 cm aneurysm, there's definitely some aortopathy that stent graft unfortunately will degenerate and will look bad.
Absolutely. So again, our goal is to improve aneurysm awareness for the population, and also down the road establish a team for endovascular coverage, because it's a huge country and we don't have centers of excellence around here. So we have to create some centers of excellence at certain locations. So if somebody has an aneurysm that's ruptured in point A, you don't want to travel 6-8 hours to point B. They'll be dead before they get there. So that's another initiative we might need to take on. So again, thank you very much for helping us out. We appreciate it, and we'll talk to you later. Any more questions for Dr. Shadi?
I had a
No
question,
questions from
Dr.
this end here. Thank you so much.
I had a question, Dr.
Thank
Oye.
you, buddy. Okay, yes. Yes.
Yeah,
Go
I
ahead.
wanted to ask, you talked about the limitations of CTA for visualizing the endoleak. I was wondering, do these new imaging modalities such as 4D, four-dimensional CT, do they offer a better way to visualize the type 4 or type 5 endoleaks?
Thank you. It's a good question. Yeah, I think again, the more imaging we do, the better visualization endoleak. But the problem that we see here is not just a truly endoleak. It's not just a pressure comes from a blood flow that comes in. What would happen is the aneurysm itself clots, and that's what we learn is there's a big clot sitting in the aneurysm, and there's a hole in the graft, and that creating too much pressure in the sac itself. And it's like a direct connection to the aneurysm. Even a regular aneurysm, before you put a stent in them, there's a lot of them they are layered with thrombus. And people at one point say, well, the thrombus is protected from the aneurysm getting ruptured. No, it didn't protect the aneurysm getting ruptured. So if you put a stent inside it, which comes to, it's mainly in Europe, they come up with the idea of putting, especially for like thoracoabdominal aneurysm, they put what we call multi-layer stents. And they said it will probably depressurize the sac because you don't see any more leaks. It literally creates thrombus in the aneurysm itself with the small tracks for the branches. And what we learned the hard way is these patients will still rupture. They decompress some of them, but still the risk of rupture is still there. So if there is a direct connection between the aneurysm and the clot itself, it will rupture. So you have to be careful. So the modalities are helping. We're catching some of the endoleaks like type 2s and type 3s, but not all of them. And that's why it's like, if you can't see it and the aneurysm getting bigger, just don't wait. Just do something. Again, relining it probably is the easier option, but a lot of time you just have to do open repair. It's more definitive.
Thank you.
Thank you. Thank you, doctor.
Have a good day, man. Thank you so much, man.
Thank you. Have a good day. Appreciate it.
Our next speaker will be Dr. Arun K. Singhal. Dr. Singhal, are you there?
Yes.
Was that?
Yeah. Okay, I see him. Dr. Singhal.
Thank you.
I'm going to do a brief introduction on you, Dr. Singhal. So Dr. Singhal is a distinguished clinical professor of cardiothoracic surgery at the University of Iowa. Dr. Singhal holds both an MD and a PhD and is a fellow of the American College of Surgeons. His clinical expertise encompasses complex aortic disease, valve repair and replacement, minimally invasive cardiac surgery, and structural heart interventions. Today, he will share valuable insights drawn from his experience and innovation in cardiothoracic and vascular care and discuss incorporating AI into aortic surgery clinic. Please join me in welcoming Dr. Arun K. Singhal.
Thank you. Do you have my slides or do you want me to share?
I got it, but if you would like me to share it, I can.
That would be great. Thank you.
All right. They should be coming up anytime now.
Thanks. So, thanks again for the opportunity, Dr. Oya. You've been too kind in inviting me. And really, unlike I've been listening to these, they've been great clinical presentations. We're going to have a slightly different talk here, and this is going to be about the future, where I perceive the future of aortic aneurysm measure going, and some of the tools. And the biggest tool that I want to talk about. Next slide, please. Next, please. The biggest tool I really want to talk about is AI. And this talk is not so much about AI being artificial intelligence, not aortic insufficiency, but artificial intelligence, is that it amazes me that we're having a talk with people all over the world on Zoom. And I think AI is going to more dramatically change our world than the internet did. And I think it's critical that all of us in practice, wherever we are in the world, start learning how to interact with AI. I think it's a critical topic. Just learning how to interact with it is much more complex than learning how to interact with the internet. And so we've started applying this program, this technology. I'm not even sure we should call it technology, but this tool set technology, brilliance to aortic aneurysm surgery. And the only thing this slide is supposed to show very briefly is that the ascending aorta, which is in yellow, has a very different embryologic development than the rest of the entire vascular tree. And it's elastin rich. And really, I don't expect you to remember this. I don't expect you to understand this, but just remember that the ascending aorta reacts differently. Next slide, please. And, we know that's true in many different ways. One way we know is, for example, the growth rate of aneurysms in the ascending aorta is very different than the growth rate of aneurysms anywhere else in the aortic system. Next, please. So we're going to break this talk into three parts. One is to talk about what the present guidelines are. Then we're going to talk about the limitations. And lastly, we're going to talk about the future of AI in this field. So this basically looks at what we do know. We know on the bottom of all these slides on the x-axis is really aneurysm size. And there's different studies here. Some are out of the Yale group, some are out of different groups all over the world. And essentially, I think most of us, even if we aren't cardiac surgeons, but just in general, vascular surgeons, even physicians outside of the surgical specialty know that as aortas get bigger, the risk of complications increase. Those risks are rupture, dissection, death. And most people know that those risks dramatically increase somewhere in the 5 to 6 centimeter range. And these various studies from different places to show that, next slide, please. And so when you look at the recommendations for, and these are about the American Heart Association, and the European societies have also given the same, essentially the same sort of recommendations and guidelines, is essentially the guidelines say that once the diameter is over 5.5, you should proceed to surgical repair. That's in the top left in green. But the summary is of all the clinical data and historical data on clinical behavior has been summarized to, if it's more than 5.5 centimeters, you should go to surgery. Next slide, please. But if we look at this, there are some shortcomings, and I'm going to show you that over the next few slides. Next, please. For example, if you look at patients that have type A aortic dissections or aortic dissections of the ascending aorta, according to this study out of Europe, 60% of patients, the diameter is less than 5.5. So a guideline that we use to prevent this complication, more than 60% of the patients will get to this complication before they hit the guideline recommended point for elective intervention. Next slide. Essentially, I'm going to show you through a series of slides the same thing over and over and over again, that the mortality in type A dissections occurs for the vast majority of patients well before 5.5 centimeters. Next, please. In fact, if you look at it, 97, according to this data out of the US, 97% of dissections occur before 5.5 centimeters. So just to sort of put things in perspective, guidelines say you should operate after 5.5 centimeters because that's when the risk is highest. Yet the complication we most fear in ascending aortic dissections occurs 97% of the time before you hit the guideline recommendations. Next. And that seems to be independent of male or female or age. So this appears to be true across all age groups. Next, please. And for example, let's just look at one thing. We know that, for example, that we use diameter because it's easy for us as surgeons, even if we're not experienced radiologists, it's very easy to look at diameter. It's easy to measure it. You just go up and down the slides, you find the one where you think it's the biggest, and you measure it. And if you're off by one or two slices on the scan, it really doesn't matter. But if you really start looking at some of the data, for example, diameter is much more consistent. So on the left, we have diameter, length, and volume, and on the other, on the overall, the sensitivity predicting the risk of dissection. And we find out that overall, length, for example, and diameter, which are very hard for us to measure, are much more sensitive and specific than, for example, length and volume are much more sensitive and specific than diameter, which is the guideline that we use most. And we use it because it's easy. It's easy as humans to really measure diameter. It's very hard to measure volume. It's very hard to measure length, especially in a structure that is curvilinear, that's curved as it leaves the heart and gets up to the arch. Next, please. And there's other things we know as surgeons. We know intuitively that root type aneurysms, for example, are much more dangerous than ascending aneurysm, and fusiforms are in between root and ascending types. But those aren't incorporated into the guidelines because they're hard to quantitate. We can look at them. We as humans know the difference across the board, but they're hard to quantitate. Next, please. And similar things, we know technically how hard operations are just depending on how the arch is laid out, whether it's an arch where 3 branch vessels are linear in their takeoff, or an arch vessel is like type 3, where managing the subclavian becomes quite difficult as surgeons. Next, please. So we can skip this, please. Thanks. So really, the important thing becomes we've taken a lot of data, and because a lot of it has to do with how we as humans process data, we use a single parameter, diameter, as a judgment-making tool. We ignore things like length and volume because they're hard to measure. We don't incorporate different anatomic shapes because they are difficult to quantitate. We don't incorporate biomarkers and so forth because we don't know how all these things mix together. these are the kind of problems that AI is excellent in managing. In some ways, it has the ability to take a lot of different knowledge from different sources, incorporate it into a single decision making. Next, please. So just to really start talking about why we want to fix aneurysms. I know we don't think about this, but we all know this intuitively. An aneurysm, bad things occur in aneurysms because the wall stress is greater than the wall strength, right? When that ratio changes, at some point, we will have a problem, either a rupture in the abdominal aorta, a dissection in the ascending aorta, but it's a very simple equation. And right now, we have really simplified that problem into a wall stress problem. All of you probably recall Laplace's law, which says wall stress is a function of the radius squared. And so we've taken the pretty complicated relationship, thrown out a lot of information because we can't process it, and simplified it to one parameter, R, which is the radius, and we use serial CT scans. One difference is that the AI doesn't have any problem doing physical analysis on the whole scan. It doesn't have problems looking at stuff like length and volume and diameter. It doesn't have problems starting to look at differences in wall thickness. And all of this can now be fed into a single artificial intelligence program, which is really able to incorporate every little piece of data to give you individualized measurements. Next, please. Yeah, thanks. So I'm just going to talk you through how we've sort of thought of the problem. I know this is a vascular conference, so maybe not as many of you think about the problem of aortic dissections, but aortic dissections almost always occur at the root, at the very beginning of the aorta, not at the area where the diameter is the largest. So we intellectually have a problem because our guidelines say that dissections occur at the highest area of highest radius. But clinically, we know 80+% dissections begin at the aortic root, regardless of where the maximal diameter is. So one of the first things we started looking at is trying to, I'm going to simplify the process, but trying to look at the aortic root, which is the origin of most dissections. And we started looking at the root in an automated fashion. If you tried to do all this work by hand that we've shown you that we've now automated, this for me is 30 to 45 minutes to even an hour of measurements, pretty intense measurements, to try to find these various measurements, the Laplace's radius, where we assume each part of the coronary sinus or the beginning of the aorta is really three different structures rather than one structure, as we show at the end. But we are able to do this all within a minute or two with a combination of image processing and aortic artificial intelligence. Next, please. And on top of that, so I sort of said, AI can just start there, and it can start, first of all, it can do simple things. It can take a complicated structure and it can straighten it out, like a lot of times, like maps that we've seen of the world, which are, take this round globular globe and make it a flat image. It can do what's known as center line. It can draw an artificial line to measure the length. It can measure the diameter at defined points. So we have this ability now to do all of this, I would say almost instantaneously. Next, please. And so we first start off with trying to understand, if we set off a computer program to do this for us, what would it mean? So we took the Laplace's radius and we took just the root. So this is just the first 3 centimeters of the aorta. And on the bottom, on the x-axis in all of these, on the top three, is what we measured in terms of the radius of the left, right, and non-coronary cusps. And on the y-axis is what we had the computer measure. And R squared, the important thing is R squared here in the top three. And all the R squared says, the closer it gets to 1, the closer the two systems are to each other. So obviously 1 is perfect. And remember, the assumption here is the human measurements are right and the machine measurements are wrong, okay? But the critical thing is they match. Now, who's to say which is right and which is wrong? But we're starting with the assumption that we as humans are right. And we did the same thing for calculating. If you remember in the few slides back, I had 3 colored balls to remember to measure the area or the volume of these 3 structures in the root. And we similarly found that we had pretty good correlation. Again, R squared on the bottom is the area where we cut the aorta and measure them by hand versus we had a computer measure. Next, please. And so this is just another way of looking at that thing. And what you see is that across these measurements, when you look at them, and we'll just stick to the top left bar here, is the left coronary sinus has the highest radius, and the right coronary sinus has a smaller radius, and the non-coronary sinus has the smallest radius. So your assumption would be, you know, what the rules teach us, what we know is the bigger the radius is the more likelihood of a dissection. But we know that's not true. Actually, if you look at where dissections occur, the Laplace's radius is the dissections most commonly occur in the non-coronary sinus, less frequent, about 80 to 85%. About 14% occur in the right coronary sinus, and only 1% occur in the left coronary sinus. So we have a problem here. We have one piece of data saying, hey, they should occur in the left, but we have another piece of data saying, really, the left is the largest. So we have conflicting data. And then you start looking at 2D area, and all of a sudden you see those ratios start changing. And we go to the next slide, please. And we can skip this. And let's go to the next slide, please. 3D, now we start looking at other things like 3D volumes, which is really, if you think about stress in a very simple word like a water balloon or something, stress is really a function of the volume. We only use radius because it's easy for us, but volume it is. And now all of a sudden, the ratios start changing. The left coronary sinus has the smallest volume. The non-coronary sinus has the largest volume. And for clarity, it's almost impossible as human beings to measure these volumes. It's just too hard. We couldn't do it. We had to train the system to do radius and then to do area. The AI was able to measure volumes. So all of a sudden, we're starting to explain clinical behavior, which we've intuitively known. We've known as humans. We know from doing these operations, but we've never been able to explain. Next picture, please. Next slide, please. So this is just a very brief survey that I would just ask the audience to spend a little bit of time in a very thoughtful manner on learning AI, and learn it now, because you don't want to be the point where it is showing up every day in our practice. And here for me, it shows up every day. My notes are now taken by AI in my clinic, for example, and it shows up every day on my medical record screen on what I have or haven't done for the patient. And you want to make sure that you're not a passive recipient. But I will tell you that we're using this tool, and we hope to really incorporate this tool in managing ascending aortic diseases, in a particular case for surgeons. Thank you. I'm happy to take any questions.
Any questions from the audience here?
Yeah.
I have just a comment for the audience and for you, doctor. Can you hear me?
Yes.
Can you hear me?
Yes.
Okay, yeah. Thank you for the fascinating talk again. I appreciate the opportunity to hear you once more. We know the future of AI is here. And if we don't adapt our clinical practices or match AI, we'll be left behind. Again, with respect to AI and cardiac work, with respect to AI and vascular work, with respect to AI and the clinics, it's here to stay. There's no question about it. Matter of fact, it's the wave of the future. So I hope the listeners would have picked up on your message on AI, because it's here to stay. And we thank you so much again for giving us the opportunity to talk to us and give us that insight once more about AI and how we should think about AI as the wave of the immediate future. Thank you so much again.
We have a question here from the audience.
Thank you very much, Doctor, for this opportunity to learn. Based off of the information you gave us, you told us that the guidelines we go into fix aneurysm when the diameter is above 5.5. But the question I have is, based off of your clinical experience so far and your wealth of knowledge, when do you intervene? Do you wait until it's up to 5.5, or do you just have your own way of determining when to go into fix?
You know, right now I stick to the guidelines.
Oh, okay.
And I will talk you through my process for this. The mortality for an elective operation in a ascending aortic surgery is 2%. And the mortality from emergency dissection is probably closer to 15%. So you would have to do 7 elective repairs correctly in order to save 1 dissection. Secondly, for every 50 to 100 patients I see with aneurysms less than 5, I only see 1 or 2 with aneurysms over 5.5. So right now, I'm not personally insightful enough to say, hey, I look at this. I look at some, they really scare me, but it's very different than taking someone to the operating room and giving them a 2% mortality when I don't have enough insight to take someone and say, I'm going to put you through an operation where you have a risk of dying on a hunch, on a thought process, without having a strong enough case of clinical knowledge to back up my decision. Does that answer your question?
Yes, sir.
I would ask all of you, if you get a chance, the best way to learn to use AI is, I'll give you an example of what I'm writing a paper right now, and I wanted to know what the bleeding rate was. And I had a rough idea of what it was, and I asked AI, and I was looking at VSD repairs, and it said the bleeding rate is 38%. I asked AI, the next question I asked is, where did you get that bleeding rate? And it pulled up a reference. Then I said, can you show me in the reference where that number came from? Because the number didn't make sense. And it says, oh, it was a mistake. The rate is really 11%. So before you start using AI as an everyday companion in your life, I would say start using AI as an everyday companion in the areas where you feel that your knowledge base is the strongest, and really start learning, hey, how does it really match to what I know? And I think 70 or 80 or 90% of the time, you'll find that you know more right now than the AI companion. And by learning how to work through questions with AI, you will learn, if you get some information in an area that's new to you, how to question AI enough to realize if that data is really true or it's not true. So don't start using AI in areas where you don't understand the knowledge, or you don't have knowledge, or you don't have understanding. Really start checking AI in areas where you do have knowledge and you do have understanding and you do think you can make smart clinical decisions, because you'll learn how to talk to this technology.
Thank you, Doctor. Appreciate it.
We have a question from Dr. Cuddy.
Thank you, Doctor. That was great talk. And I think the AI subject is also something that some of us may try to avoid, but inevitably it is integrated into our practice. And can you comment a little bit on in your practice, how do you justify it, or is there any different in terms of when would you consider the repair in the patient that have the bicuspid valve? And do you always routinely do echocardiogram along with this? Would you see this patient?
Yeah. Yeah, so, the bicuspid valve data, to me, is not as simple as the tricuspid data. First and foremost, we know bicuspid patients by history do worse than tricuspid patients. So, and the guidelines suggest you may even bring that number down to 5 centimeters in bicuspids. The second thing that you really have to incorporate is valve dysfunction. Sort of right now we've talked about, or in this brief talk, we've talked as if the valve doesn't exist. But when you start incorporating bicuspids, you have to really talk about the valve itself and how it's functioning. So I do agree you treat them differently. I think trying to answer the question specifically is more complicated. But yes, I think the thresholds should be lower, and they're often driven by the valve itself beyond just the aneurysm.
Thank you, Dr. Singhal.
Thank you.
I don't really have a question. I just want to mention that AI, like you said, is emerging and it's kind of creeping into every aspect of our life, whether it's our day-to-day life or for us physicians or future physicians, the healthcare aspects of our career. And I remember I was reading a study done by a Norwegian physician group who discovered that AI could actually predict the risk of AAA rupture better than common guidelines would expect. And I found that very interesting. So I look forward to seeing where AI goes in the future. Our next speaker is a medical student, Jordan Polo, who will be talking about physician burnout.
Hello, everyone. Nice to meet you. My name is Jordan Poe. I'm a student at Avalon University. I'll be presenting my case on prevention of physician burnout and suicide. So one of the first big topics to talk about is what exactly is burnout? So burnout is a form of fatigue that associates with feeling being constantly depleted. This stems from experiencing mass amounts of emotional, mental, or physical stress for extended periods of time. Commonly, burnout is thought to relate solely to a person's job, but it can also relate to other areas of your life and even your health. Now, burnout is not to be confused with stress. Stress results from too much mental and physical demands that can have you feeling overwhelmed. And emotionally, it can lead to feelings of irritability, agitation, where burnout is too little emotion, drive, or care to complete your daily tasks, where this is having feelings of apathy or little emotion. Now, causes of burnout will be unmanageable workloads, unfair treatment at work, confusing work responsibilities, lack of communication or support from managers, immense deadline pressure, too much work, not enough time to really rest or downtime, a feeling that work or life is out of your own control, a feeling of being unrecognized or unrewarded, work or responsibilities being too demanding, boring or routine work where you're not feeling a challenge, lack of sleep, a few supportive or meaning relationships, and personality traits, whereas perfectionism, pessimism, and a constant need for control. Now, burnout versus depression. Burnout can present like depression, but it's imperative to be able to differentiate the two. People who with burnout have little motivation, emotion, or care for the usual daily activity, and it can be eased away with time off from a reasonable stressor. Depression is a mental illness that does not go away even after the person is individually resting for an extended period of time. Depression usually for the criteria that we meet is feelings of anhedonia, lack of sleep, lack of energy, fatigue, a feeling of guilt and suicidal thoughts for more than 2 weeks. Now, there are 3 different types of burnout. You have overload burnout, which is working harder and more frantic to accomplish your tasks without taking proper time or rest or downtime. This type of burnout is usually the most common seen in dedicated physicians, which can lead them to mental and physical exhaustion. Under challenge burnout is where you're not really feeling a worthy challenge or stimulated enough, where the work is really tedious and monotonous, leading to underappreciation, frustration due to lack of learning opportunities, self-improvement, or proper relationship with colleagues. The third one is neglect burnout, where this is a feeling of hopelessness in front of challenges. It occurs usually when someone isn't given enough structure, direction, or guidance in the workplace, causing difficulty to keep up with demands or unable to meet expectations. This one is usually seen a lot more with medical students and residents. Now, COVID-19 had a massive effect on physician mental health. Alongside the rest of the world, physicians were heavily impacted by the outcomes of COVID-19. Physicians are trained to save lives, took an oath to do no harm. So when physicians are faced with extreme increase in death tolls, it caused an immense amount of stress and depression that were not expected to deal with. The World Health Organization recorded 1,813,188 official COVID-19 deaths by December 21st in 2020. However, preliminary estimates suggest that the death tolls exceed far more than that, estimating approximately 3 million reported in 2020. Not only were physicians faced with an increased number of dying patients, but they were also faced with challenges such as a lack of available personal protective equipment, which would ultimately intensify their fears and anxiety of potentially contracting and spreading the virus. Also, due to an extreme growing number of infected patients, patients had to take on more shifts and longer hours, which meant longer time spent away from home and family during a crisis where support was needed the most. This added on stressor contributed mostly to physicians' burnout. Now, physician burnout rates. Luckily, physician burnout rates have since declined since 2025. According to a 2025 Stanford medical study, physician burnout has decreased from 62.8% in 2021 to 45.2% in 2025. Although there has been a decrease, a burnout rate of 45.2 is still considerably high. In 2020, approximately 38.2 physicians reported feeling some symptoms of burnout. However, by 2021, reported physician burnout rose to 62.8. Female physicians recorded an increased amount of burnout rate compared to their male physicians, where for females it was 58.6 versus the 39.6. Amongst specialties, physicians in oncology, primary care, and emergency medicine had the highest case of burnout. The fast-paced environment and little paid time off further contributes to physician burnout and that emergency medicine specialists faces. And several surveys have reported emergency medicine specialty the highest recorded case of burnouts exceeding more than 60%. So here we're showing, like, in order, the amount of specialties that we have from top to bottom, that the main top three I mentioned before being emergency medicine, OB-GYN, and oncology, and then followed by pediatrics. So one of the reasons as to why ER could be one of the most top of the line and top of the list causes of burnout is the unpredictable high stress situations from trauma, critical illness, and deaths of patients, the long and irregular hours, frequent night shifts, and limited time for recovery, a high patient volume and loss of control over workflow, frequent violence and hostility as violence against healthcare professionals is on the rise, and administration overload. For obstetrics, it's the high states and constant liability, the direct impact on women and babies, unpredictable schedules, deliveries and emergencies, and emotional instability. Now, what contributes the most to burnout? Now, this survey was taken by Medscape, and it shows that at the top of the list, we have too many bureaucratic tasks, such as charting, paperwork, dealing with medical billing, too many hours at work, the lack of respect for administrators, employees, or staff, insufficient compensation, a lack of control and autonomy, the computerization of practice, lack of respect from patients, government relations, and others. Now, physician suicide rates. Every year, 300 to 400 physicians die by suicide. In the US, suicide deaths are 250 to 400% higher among physician females when compared to other females in other professions. In the general population, males complete suicide 4 times more often than females. However, female physicians have an equal rate to male physicians. Among physicians, risk of suicide increases when mental health conditions go unaddressed, and self-medication occurs as a way to address anxiety, insomnia, and other distressing symptoms. Now, ways to reduce burnout and suicide rates. It's recommended to seek help in managing your stress. Burnout can make you apathetic and less likely to help yourself. We recommend turning to friends and family to talk about how you're feeling, or even therapists. Spend quality time with your loved ones, engage socially, talk or have lunch with your colleagues, avoid interacting with negative people. Engage in volunteer work, religious organizations, or support group where you can talk to people who enjoy the same activities as you, or are even suffering from the same conditions of burnout or depression as you. Change your attitude around your work. You can't always change your job, but you can change how you feel about it. You can find something to value in your work. We recommend taking a vacation or extended leave to remove yourself from work stress, then disconnect to your job completely. Set priorities, slow down, reconsider your goals and life work. Practice saying no and setting boundaries. Exercise. Exercise can help lift your mood. Aim for 30 minutes a day, but even a 10-minute brisk walk can boost your mood for several hours. Eat healthy, limit sugary and carbohydrate-rich foods that can lead to a dip in energy and mood, and avoid caffeine and nicotine, 2 stimulants that can affect your mood. Thank you, everyone. That's the end of my slides. Do you have any questions at all? Or?
Thank you, Dr. Jordan. I appreciate it. Nice job, very thorough. Any questions from the audience? Again, it's important to know that this is a fact of life. The reason why I did ask Dr. Jordan to present this topic is because it's a common problem in the US. And I'm pretty sure it's a common problem here too, you know, and people do take their lives, and it's a reality. We had a physician who was double boarded, otherwise doing really well, take his life. You know, it's somebody we personally know. So again, that physician could have talked to me if I knew he was having that problem. I could have invited him to Nigeria and he could have been just fine. But he elected to take his life. So again, those are real things that occur. That people do have stresses. If you have a problem, talk to your priest, your pastor, your family. You know, if you're not getting help, seek professional help. It's important. Yeah, thank you so much. Yeah, let's go to the last speaker, please.
All right, ladies and gentlemen, our last and final speaker is a veteran cardiothoracic, vascular, and thoracic surgeon with over 4 decades of experience. He not only holds fellowships in the American College of Surgeons, however, is also a fellow in the American College of Cardiology and has earned a PhD in addition to his DO degree. He has served as a chief and director of vascular and cardiothoracic services at West Regional CTV Surgeons and contributes significant leadership in endovascular and open surgical care. Dr. Harold Tabai and his extensive practice spans vascular surgery, thoracic surgery, complex endovascular interventions, and multidisciplinary care for high-risk patients. Today, he will speak on the evolution of cutting-edge cardiovascular and thoracic surgery. Please join me in welcoming Dr. Harold Tabai. Dr. Tabai, you're muted.
Can you hear me now?
Yeah, we can hear you now.
Thank you so much, Dr. Roy. And good morning or good afternoon. Here is morning. Good afternoon to everyone. Today, I'm not going to be talking about procedures, surgical outcome. I'd like to go back to the pioneers and those who set the stage and foundation for our work today, and with the hope that we also set the stage for a higher level and to help transcend our fellows and residents to a higher degree. Next slide, please. Well, going back to the innovations and pioneers in the chest surgery, in 1628, William Harvey discovered the motion of heart and blood circulation in animals, which was published in the book translated The Motion of the Heart. In 1893, Daniel Hale Williams performed the first successful open chest surgery. He opened the chest to repair a blood vessel, which had occurred as a stab wound. His work was a significant breakthrough in a medical history because at that time, opening a chest, go back please. Opening a chest was very, very dangerous. He was the first African-American surgeon who pioneered the sterile surgical technique. His operation marked a major milestone in cardiac surgery decades before the heart-lung machine was ever invented. Next paragraph, next slide. I can't handle myself. Next slide. In 1896, Ludwig Wren performed the first successful suture repair of cardiac injury. Ancient contributions in early vascular surgery, such as phlebotomy, traces back to ancient Persia, Greece, and Rome. Next. In 1902, Alexis Carrel performed the first successful suture anastomosis of 2 small blood vessels. You can see how far we have come. 1923, Elliot Cutler conducts the first successful heart valve surgery. He went trans-thoracically to perform a mitral commissurotomy using a tenotomy knife for rheumatic mitral stenosis in a 12-year-old child. 1938, Robert Gross performed the first successful ligation of patent ductus arteriosus in a child. Next. 1952, Floyd John Lewis performed the first open heart surgery using hypothermic for cardiac arrest. 1953, John Gibbon invented the heart-lung device, allowing the longer surgeries. His innovation of heart-lung machine revolutionized procedure time and longevity. And he also performed the first open heart surgery. Next, 1958, Mason Jones accidentally injected contrast dye into coronary artery during catheterization, leading the first selective coronary angiography and the birth of modern cardiac imaging at the Cleveland Clinic. Next. In 1986, Ulrich Sigler performed the first implantation of stent to manage an acute occlusive dissection post-angioplasty. The same year, Jacques Paul was the first to implant stent in a human coronary artery to treat restenosis after balloon angioplasty. Next. In 1960, Robert Goetz was the first to perform a valve surgery. He performed the first bypass surgery using a stapling device, performing CABG from using the right IMA to the right RCA with a staple on a beating heart. The patient recovered, and the patency of the valve of the graft was confirmed post-operatively. Later in 1967, Rene Favaloro at the Cleveland Clinic pioneered the first sutured CABG. Next. In 1952, Charles Hufnagel developed the ball cage valve and performed surgery in a patient with aortic insufficiency. He implanted it in the descending aorta. Following him, next paragraph, Starr Edward perfected the valve, made it more accessible with his engineer Edwards. And they call that Edward Albert Starr or Starr Edward and Lowell. Starr Edwards valve. He was the first to pioneer valvular surgery by performing aortic replacement using the new ball cage valve. He revolutionized the field of valvular surgery. His valve was used for a long time, but because of the sound and because of the noise, a lot of people did not like it actually, and I believe that some committed suicide because of the sound, and some had to be replaced with a new valve. Next. Following Starr Edward, there were other valves invented. Next was the tilting disc valve, which, as you see, was just one disc, which tilted back and forth. But there were a lot of complications, dislodgement of the disc, clotting. And I had the misfortune of having two patients. One had came to the operating room, to the emergency room, in cardiac arrest. We put him on a heart-lung machine from the groin in the emergency room and cooled him down, take him to the operating room. The echocardiogram couldn't find the disc. We opened the aorta, it wasn't there. Opened the ventricle, wasn't there. I just happened to feel the neck, and I felt the lump, opened the carotid, and that's where it was. We replaced the valve, and luckily he made it. Another patient came in with totally occluded annulus. The valve was stuck with clot. The same thing, we had to replace that with a St. Jude valve. Later, St. Jude valve was invented in 1977. It was implanted for the first time at the University of Minnesota successfully, and now one of the best mechanical valve being used all over the world. Next. Next, in 1967, Christian Bernard performed the first human-to-human heart transplant in South Africa. Later in 1983, immunosuppressants revolutionized post-transplant care. That resulted in improving organ acceptance and longevity. Next. In 1999 was the first time that robotic surgery was actually used. I was involved with a company called Computer Motion, which was actually in Santa Barbara, California. We worked for a couple of years to create the actual robot, which was compact and surgeon friendly. Spent many hours to find actually the port system, where to place the port to see the LED, and for instruments it was not so easy. Now people use the ports very easily, not realizing how much work was put into this. I wrote the first paper regarding port placement, and we did a lot of animal studies with Ralph Damiano. And finally, in 1999, since we couldn't perform the surgery here in America, we had a surgeon in the company who was a heart surgeon from Russia. He arranged for us to go to Russia. So we went there, and after the second day, we were able to perform the first bypass surgery in a closed chest robotically in the world, which was a great day. It was actually in July of 1999. Subsequently, I came back and gave a lot of talks here in the US and around the world. We started the first feasibility study after 29 patients between myself and Damiano. We wrote this feasibility study, gave it to the FDA. FDA allowed us to select 15 other hospitals to perform. And after that, of course, with the success, everybody else started around the country, in North America and also in Europe. Next. Following the computer motion, Da Vinci came to picture, and Da Vinci purchased computer motion, made computer motion obsolete because they didn't produce the arms or the parts that was needed. So everybody had to buy Da Vinci. So Da Vinci was then approved for cardiac and lung surgery. The first valve surgery was performed by Carpentier in France, robotically assisted mitral valve repair. Subsequently, Chetwood in America did the same thing. Next. The modern innovation in cardiothoracic and vascular surgery from 2000 to present. In 2000, there was introduction of minimally invasive techniques, both manually and robotically assisted cardiac surgery. In 2000, stent grafting becomes a widely used treatment for the aortic aneurysm. And in 2000 to 2025, the use of artificial intelligence and 3D printing in surgical planning and valve replacement and future innovation. Next. In 2002, Alain Crebière was the first to perform transcatheter aortic valve replacement in Rouen, France. His work revolutionized the treatment of severe aortic stenosis. Next. Historical overview. 1896, the first successful heart surgery by Ludwig Wren to repair a stab wound. 1902, first successful pulmonary resection for tuberculosis by Frederick Trendelenburg. 1933, first successful pneumonectomy for cancer by Everett Graham. 1940, development of vascular surgery during World War II by Dr. Michael DeBakey. Next. 1932, Michael DeBakey designed the roller pump for blood transfusion. First successful arterial repair and graft surgeries developed during World War II. 1950s, the first aortic aneurysm repair was performed by Michael DeBakey. Next. In 1960, he developed the carotid endarterectomy and shunt. Next. 1967, first human heart transplant by Christian Bernard in South Africa. 1980, introduction of cyclosporin, improved transplant survival rates. Now modern era, LVADs and improved immunosuppression have enhanced longevity. Next. Next. In 1982, the first go back, please. In 1982, first permanent artificial heart implanted, that was Jarvik, by Barney Clark. Syncardia and Abiocor have advanced artificial heart technology, which are used as bridge to transplant and destination therapy. Next. Transcatheter aortic valve replacement for aortic and mitral valve stenosis and regurg. Endovascular aneurysm repair for ascending aorta, aortic arch, descending aorta, and abdominal aorta for aneurysmal repair. And 3D printing for surgical planning and prosthetic design. Next. Zeus from Computer Motion was the first FDA-approved robotic device for both CABG and cardiac valve surgery. Subsequently, Da Vinci robotic system was approved by FDA for thoracic surgery and CABG. Video-assisted thoracoscopic surgery, VATS, in robotic assisted VATS. The benefit of these was, of course, smaller incision, less pain, quicker recovery, but much longer surgical time. Next, please. In 1953, the first successful use of heart lung machine by Dr. John Gibbons, and he's the one who invented it. 1958, first successful internal pacemaker implanted by Ike Senning. 1960, coronary artery bypass graft developed by Dr. Rene Favaloro at the Cleveland Clinic. 1970, balloon angioplasty pioneered by Andrea Grunzek. Next. 1980s, use of cyclosporin revolutionized cardiac transplantation. In the years of 2000s, introduction of minimally invasive valve surgeries. 2010, advancement in percutaneous interventions such as MitraClip and Watchman. In 2020s, integration of AI and machine learning in surgical planning and diagnostics. And in 2020s, development of bioengineered blood vessels and heart tissues. Next. Here is an example of triluminate, TriClip, as you see for mitral regurgitation. It's an end-to-end approximation of the tricuspid valve. The same, it's called MitraClip. It's used endovascularly for mitral regurgitation. And the Watchman is used for occlusion of the left atrial appendage. I actually started occluding the left atrial appendage in 1993 on. I was questioned for doing that. I was written up and so forth. And finally, when the data came out, they felt that maybe I was right. But now we know that left atrial appendage is the cause of clot formation. And as a result, most patients who have especially atrial fibrillation or undergo valve replacement, the left atrial appendage is occluded. This is the form of endovascular procedure with a Watchman. Next. The CardioMEMS is revolutionized the treatment of congestive heart failure. Is a wireless implantable device that monitors pulmonary artery pressure. especially of course, in patients with heart failure. It helps healthcare providers to detect early signs of heart failure, decompensation, and intervene promptly to prevent hospitalization and improve outcomes. Next. Innovation of cardiopulmonary bypass. In 1953, the heart-lung machine allowed successful open heart surgery. Modern machines are compact, efficient, and safer. Modified ultrafiltration techniques reduces post-op complications. New perfusion strategies target organ protection during surgery. We have come a long ways from the early on with the cardiopulmonary bypass machine. They are very compact now. In fact, my perfusionist has developed a very small pediatric size cardiopulmonary machine, which only primes 250 cc's. It can be used for adults or for pediatrics. We actually barely use any blood transfusion. I'm one of the dedicated surgeons for Jehovah's Witness, and using this compact cardiopulmonary bypass has helped significantly. Next. Next slide, please. Transcatheter mitral valve and tricuspid valve repair is already in use, as I showed you, ultra-illuminate. The new generation LVADs, HeartMate 3, has shown improved survival and fewer complications. Stem cell therapies for myocardial regeneration in advanced trials. Implantable sensor technology such as CardioMEMS that we just alluded to helps and monitors heart failure patients. Next. Artificial intelligence used to analyze imaging, predict surgical risks, and customize patient care. Machine learning models aid in intraoperative and preoperative decision-making. Big data enables personalized treatment pathways and benchmarking outcomes. And remote monitoring through wearable devices integrates with electronic records. We have come a very long ways, and we have a lot to go to. Next. The future directions of bioengineering, tissue-engineered heart valves and blood vessels. It's in development. Fully implantable artificial hearts with no external drive is also being worked on. Gene editing tools explored for congenital heart conditions is being worked on. Remote and telesurgical procedures using 5G and robotic platforms also is in the future. Next. These are all the procedures we have been performing and we are performing now. It used to be all open technique. Now we're doing them, we have choices, open versus minimally invasive or totally endoscopic. We have the technology now to make it easier and safer for the patients, depending on their cases, from single vessel, multiple vessels, aortic valve, mitral valve, pneumonectomy, pleural effusion, aneurysms, mediastinal dissection. Everything can be done now, minimally invasive or, of course, open technique. I actually missed cutting and sewing because that was more challenging, but now, of course, it's a different world. Next paragraph. Next slide, please. Coronary bypass. This is what we used to do. Surgical approach was either conventional bypass, open technique, minimally invasive, using mid-cap or keyhole operations, off-pump coronary bypass, port access coronary bypass using hard port, and now robotics. Next. Well, incision we used to use in the past was median sternotomy. Then we followed with upper sternal incision with an L shape. or lower sternum incision. Gradually, we went from open to minimally invasive and now endovascular or endoscopic. Next. This is the incision made for mitral valve. Of course, whether you do robotics or open, for mitral valve is the third intercostal space on the right, and the aortic valve for the second intercostal space. I actually feel right now that since the various industry came out with very long instruments, doing aortic valve replacement or mitral valve takes so much faster than robotics. With robotics, doing a mitral valve repair sometimes takes 5 to 6 hours. Doing it with a long instrument with small incision, it takes 1.5 to 2 hours at best. Less anesthesia and less holds, because I only use one port for the camera and incision in either second or third intercostal space, depending on the aortic valve or mitral valve. And I can cross-clamp, I can do cardioplegia. And then when I'm done, I have one chest tube through the camera port versus, next paragraph, versus multiple holes. This is what we had to do in the past. Hundreds of different instruments on the table, as some would get lost. And then, of course, post-operatively, counting was the problem. And sometimes we had to reopen, either find something or not find something. Next, now there's a metamorphosis of the cardiac surgeons. Please go to the next slide. Now we have few wires and balloons and a 911 blade just for a stab one to put the ports in. Next. Now, this is the anatomy of the arteries from neck down to the toes. We used to do all the areas that we used to do open procedures. Now we can perform endovascular. Faster, easier, and the patient can go home, some of them the same day, unless it's aneurysm. You usually keep them for a day. Next slide. This is how a lot of places used to harvest the vein for coronary bypass. We started at the Cleveland Clinic with just segmental incision. And now, of course, everybody is doing endoscopic. Go next one. This is how I started years ago. I actually had a patient I had operated on at the Cleveland Clinic as a resident with IMA to the LAD, which we never get, single bypass. And he found me 20 years later. He had multiple bypasses, and when we took out the vein endoscopically, he was mesmerized that he could walk right afterward. But this is one of the devices that I use from Mackay. You can use, take out the entire vein, as you know, or segments as you need. Also, you can harvest radial artery with the same technology. Next. This is a setup for harvesting the vein or harvesting the radial artery setup. Usually my PA take out the vein now. It's very, very good. And I harvest the radial artery. Next. Benefits of avoiding cardiopulmonary bypass, we all know, it avoids systemic inflammatory response. It reduces the length of post-operative ventilatory support. Less money, less resources used for the hospital, which the administration is very happy, but the perfusion is not. Decreases mortality, decreases incidence of CVA, respiratory distress, renal failure, perioperative MI, the operation for bleeding, atrial fibrillation. With the new cardiopulmonary bypass machines, a lot of these complications we used to see is reduced. So it's much safer than it used to be. Next. This is one of the devices used for off-pump bypass. I started with Cohen stabilizer. I worked with him in Boston, and it was cheap, very easy to use, and I still think that was the best. But the competition industries came out with different devices. Some of these devices were somewhat bulky, but nevertheless, everybody got used to it, and we did off-pump bypass with them successfully. I actually have done off-pump up to 6 bypasses, but not that often. Next. Now, this is a new technology started in 2021, is a GSV support. There are 2 extent and vest. Next. These are the external stents that it is pulled over the vein, which stabilizes the vein, prevents from dilatation, because the vein becomes arterialized. Sometimes they dilate, as we see when we harvest those after they come back for surgery and second surgery, and it supposedly keeps the contour, prevents from kinking, and also they claim that it decreases the intimal hyperplasia and increases the length of patency. Next. Go to the next slide, please. And next slide. This is the comparison of vest and extent. Vest has a 9-atol braided mesh. It's flexible, conforms to the vein, reduces wall stress, and focuses on physiologic remodeling. Extent is a polyester mesh, rigid circumferential support, prevents dilation, and also focuses on structural reinforcement. Extent is somewhat stiffer, and they stopped doing investigation on that, but they're working still on vest. Next. The claim is that it reduces the intimal hyperplasia. At least the early results shows that the intimal hyperplasia is less and the patency is better, but they're still working, and ongoing studies are being done. Next. This is how you use it. You use the segment of vein that is used for bypass, and you measure the size. Then you take your stent and pull it over the vein, and then you do the bypass, as you see on the right and the left slide. Next. Both extent and vest aim to improve saphenous vein graft patency. Extent provides rigid support, as we talked, and vest offers flexible support. Clinical studies suggest external support improves remodeling and reduces failure, and also reduces intimal hyperplasia. There's still ongoing trials which will determine long-term patency and effect on intimal hyperplasia. Next. This is just a picture of a graft of mine. You see the vein grafts have a stent over them. They're nice and smooth. And of course, the IMA, that you can't pull anything over it, of course. Next, there's an angio of the proximal grafts, very smooth, and it looks good. At least looks good from the video. Next, the distal, go to the next one, please. This is the next distal graft to the obtuse marginal. Next. This is the first robotic platform that I was involved in, called Zeus, from Computer Motion. Only had 3 arms, much smaller than the Vinci. The port system was only 5 millimeters. You could actually put that in a small person, on a beating heart, which would not cause any damage to the ventricle. When you use the Da Vinci, you have to have on a beating heart, you have to have a barrel chest. Otherwise, the arms are too big and perforates the ventricle. It was only 3 arms. As you see, the middle arm, we used the camera, and it called actually ESOP. We could talk to ESOP, and the ESOP would move the camera the way we wanted it. So you didn't need an extra arm. And of course, the other right and left arms were the surgeon's arms for surgery. Next came Da Vinci. Has 4 or 5 arms. It's larger. The port system are about 12. It has an embedded camera, 3-dimensional. Zeus initially didn't have that, and of course, a lot of surgeons couldn't use that because it was 2-dimensional, and it took a lot of skills to use the Zeus initially. Then Computer Motion came out with a 3-dimensional camera, but it was in the form of a goggle that you saw in that picture that I was wearing during surgery. Next paragraph, next slide. This is the console, which is for both, but it's more compact and nicer for the Da Vinci. And the pedals use your camera. Next. This is the operating room and the assistant with the arm in the chest. The assistant moves the arm and places the suture and so forth, assist the surgeon, and the surgeon sits at the console. Next. These are the number of holes. Here is about 5 holes from Da Vinci. Next. Now we're talking about T-bar. In order to perform endovascular, doing transcatheter aortic valve or aneurysm, you really need a good lab. If you're lucky, you have a very complete hybrid lab, which makes it easier for you. Stand still, C-arm, and good monitors, and spacious. That you can use robots or use basically open if you have to. Next. Adequate monitoring and lighting is needed to perform very high power procedures. You need to have in hand the 64 imaging for pre-op evaluation and measurement of your prosthetic valve, and graft that you need to be used, especially in today's that ascending aorta, the arch of the aorta, descending aorta, and thoracoabdominal aneurysms are done with grafts. So you need to have access to preoperative planning and measurements. Next. To perform structural procedures, naturally, as we know, you need expertise. You need surgical competency, you need navigation competency, and vascular competency to perform either open, minimally invasive, or percutaneous. We can't just come out of residency without training, experience to perform these procedures. It takes a few years to become competent enough to perform it by yourself. So, as we always say, the greatest lesson in life is experience. Next. Types of valves, as we know, mechanical valve and biologic valve. Mechanical valve now, what we have, which is being used worldwide, is St. Jude by leaflets. Biologic valve, we have xenograft, stented graft, stentless graft, homograft, and autograft throughout procedures. Next. This is the picture of a stented graft, a pericardial valve, very nice graft, and stentless valve. St. Jude used to also have a stentless graft, and I put hundreds of those, but you had to sew every leaflet to the aorta. Extremely wonderful valve. In fact, a lot of the times I put the valves in, cardiologists would do echocardiogram. They would call me and say, "Did you replace the valve?" And they were shocked when I told them, "Yeah, the valve is changed. It looks so much like a normal valve. In fact, I put the same valve in one of my cardiologists, the chief of cardiology. But then St. Jude took it off the market because they couldn't train enough surgeons and they were not making enough money. So they went into the, now we have stent conduit as well. Next. St. Jude valve, bileaflet valve, the mechanical valve. Next. This is endovascular procedures, valve. This is the aortic valve, and also they have pulmonary valve from equine pericardium, horse pericardium, highly resistant balloon, expandable stent, optimal hemodynamics with durability greater than 5 years. Next. That's why you really need 64 imaging preoperatively to identify coronary osteums, because implanting a valve endovascularly, you have to be sure that you're above the osteum and does not impinge on your coronary osteums. Next. The consequence of aortic stenosis, we all know, hypertrophy, overload, and cardiomyopathy. Next. This is in situ open technique, actually partial sternotomy, which provides superior visualization, minimizes catheter and cannula from the operative field of view, allows for flexibility in incision choices, and applicable to majority of operation for standard aortic valve replacement. Next. This is catheter replacement aortic valve. As you know, you go from the common femoral and over through the arch of the aorta and down into the aortic valve. Next. This is how it's done. It's cross-sectional. You come up from the common femoral. The valve is loaded on the balloon. You place it in the annulus and expand the balloon, and then remove the balloon. And the last slide on your right is the employed valve. Next. Next, please. This is a different approach from the common femoral vein through the right atrium and across the septum, into the left atrium, down into the left ventricle, up into the aortic valve. Very complex. Next. This is transeptal approach for the aortic valve replacement. Basically, the technique is the same. You just go transeptally. Requires incision in the xiphoid to place the valve, and the same as what we talked about from femoral artery. Next. Endodirect system, it comes transthoracic through the subclavian vein. This way, the surgeon is able to place the patient on cardiopulmonary bypass, occlude the aorta, vent the heart, give cardioplegia, both antegrade and retrograde. And the valve is employed through the transthoracically via subclavian artery. Next. Well, ischemic mitral valve disease has a very high prevalence, but undertreated. As you see, there are complications of untreated is listed here. Enlargement of ventricular leads, annular enlargement, decreased leaflet coaptation, increased regurgitation, then goes to left ventricular dysfunction, reduced efficacy of the heart, and increases ventricular size. Next. This is a totally endovascular procedure. This is exactly like annuloplasty ring, but from the outside, it causes coaptation of the posterior and anterior leaflet from going through the coronary sinus. Next, this is an animation that you're going to see. You come from the right internal jugular vein under transesophageal echo and, of course, fluoroscopy. You enter the, this is the creation of regurg, and this is the stent on either end. So you go through the internal jugular vein, and then while you're watching the echo as well as the fluoroscopy, you go through the coronary sinus, and you leave one end at each commissure. The stent is at each commissure. Then you balloon it, open it, and that reduces the annular size and bring it and cause coaptation of both posterior and anterior leaflet. They are all totally endoscopic. Next, a pulmonic valve. This is bovine jugular vein for pulmonary valve replacement. Next, you go from catheter directed, go through the common femoral vein, across the tricuspid, and into the pulmonary artery, and the employment is exactly the same. Again, it's loaded on the balloon expands it, and then you remove the balloon, and that's it. Next. In order to have a lab to perform all these procedures, you need a comprehensive product portfolio for pulmonary, aortic, and mitral, whether you do on pump, off pump, or percutaneous. Next. GE64 slice is the must, along with angiography for pre-op planning, the size of the valve you need, or even if you do aneurysmal replacement with graft, you also need three-dimensional to find the exact size of the valve, graft as well. Next. Along with the coronary angiography, you also create a three-dimensional image with your 64 slice imaging, and to know exactly where the ostium of the coronaries are. So include, in case you have to put a graft in the ascending aorta, you know exactly the location. Next. Next topic is an artificial heart. Here's in 1958, William Koff and Tezuta developed this artificial heart, and they put in a dog for 90 minutes, and the dog died. 1965, again, Koff and his co-workers developed a silicone rubber heart and placed it in a calf. In 1969, Domingo Liotta was the first to implant in human this particular artificial heart, which was placed in by dental coolie. After 36 hours that this was implanted, the patient died. So you can see the development of artificial heart, how they start and where we are. It's the vision of the pioneers and perseverance of our pioneers to continue and not give up on anything until they find a good result. 1982, De Vries implanted this particular Jarvik 7, which was engineered by Robert Jarvik, Koff, and Olsen, and the whole team for the first time. Next. This is the pioneers of Jarvik 7, and of course, Denton Cooley and his engineer put the first artificial heart in, but the survival was not very good. But Jarvik 7 was helpful, and De Vries was the first one to actually have a successful implantation. of the artificial heart, waiting for the bypass or actual heart to do heart transplant. Next. Now, these are the different left ventricular assist device. This was most popular, which was used in many patients. It is axial continuous flow. It actually pumps 10 liters per minute. The size is somewhat big. It's 400 grams, cannot be put in the pericardium. It's usually placed below the diaphragm and is only bridge to transplant or destination therapy. The benefit for this was extensive long-term data was available, widely used, but the contraindication of that was high risk of thrombosis, shear stress, and driveline infection because the lines were also outside. Next. This is the thoracic could be used. It was versatile. You could put it for the left heart, right heart, or biventricular failure. A lot of people who had to have biventricular LVAD did not make it, but some did if they had the heart soon to replace it. But once you have right ventricular failure, it's very difficult. It's the most complicated ventricular dysfunction when you have truly right ventricular failure. When you have left ventricular failure, you can do a lot. So unfortunately, many of those people with biventricular failure did not make it. Next. This is Thoratec implanted. Of course, the devices are inside, but the pump is on the outside, as you see, and it's exposed. So that's why the complication, especially of driveline infection, was high. Next. This is HeartMate 3. The pump is, again, continuous flow, fully magnetically levitated rotor. It flows also 10 liters per minute. It's compact, can be put intrapericardial space, and it's used to bridge to transplant or destination therapy. The benefit: improved survival, lower thrombosis and stroke risk, better hemocompatibility. The disadvantage was, again, external driveline infection and high cost. Next. The hardware LVAD was small. It could, as you see, the pump was in the apex of the heart, pump the blood out and then deliver it and pump it into the ascending aorta. This was also configured continuous flow, hydrodynamic and magnetic bearings. Also flowed 10 liters per minute. The size was very small in impact, could be put in the pericardium, only weighed 160 grams. Indication was, of course, for bridge to transplant and destination therapy. The benefit was small size, less invasive pocket, could be used in a small person, but the contraindication was very high cost and subsequently was discontinued. Next. This is totally endovascular technique with tandem heart. It goes from pulmonary artery into the, as you see, is also continuous flow. LVAD cannulation is transseptal, goes from pulmonary common femoral across the septum and into the left atrium, and then the delivery is into the common femoral artery or descending aorta via common femoral artery. Indication is cardiogenic shock, bridge to recovery, or decision making. The benefit was rapid percutaneous insertion and has a strong hemodynamic support. But of course, the disadvantage is requires atrial septotomy, causes bleeding, septal defect, and it's only limited to short-term use. Next. Then comes Impella, which is recently used, and a lot is being used by cardiologists because they don't need a surgeon. It's primarily venous via common femoral artery. It takes the blood from the left ventricle and directs it and pumps it into the ascending aorta. The flow rate is, there are 3 different types. There's a 2.5 Impella, which flows up to 2.5 liters per minute. There's a 3.5 to 3.5 Impella, which flows up to 4 liters per minute, and this Impella 5, which flows up to 5.5 liters. It is short-term hemodynamic support, hours or days, especially used for high-risk percutaneous coronary intervention by cardiologists. Also can be used for acute cardiogenic shock and can be bridged to recovery or transplant. The benefit is minimally invasive, mainly percutaneous, rapid deployment, provides immediate LV unloading. There are different sizes, as we discussed, and can be used in the cath lab, and there's no need for surgery. Of course, the cons is the limited short-term use, risk of hemolysis, bleeding, vascular injury, requires anticoagulation, costly, and requires expertise operation. Next. This is side-by-side comparison between Impella and LVAD, especially HeartMate 3, as we discussed. One is for short-term, one is long-term, and one has to have a surgeon do it, and the other one, cardiologist. Impella, done by cardiologists. Next. Another left ventricular assist device is uses a musculoskeletal technique. It's a fully implanted system. There's no electrical power or hardware or batteries. It's used the skeletal muscle, latissimus dorsi, using normal contraction in direct tension. The energy converter is mechanical energy to hydraulic energy and used by muscle pump. And it powers internal blood, such as ventricular assist device or counterpulsation device. Next. This is a picture of the device and implantation, latissimus dorsi, and the power devices like LVAD and so forth. It's really not used that much, and I haven't ever used it, and I don't really know of anyone who has used this, but in the beginning it was helpful. There were also other devices that would wrap the muscle around the heart and stimulated the nerve conduction, but it never really worked. Next. Extracorporeal membrane, ECMO, that we know about a lot, especially during COVID. Next. ECMO is a form of life support used in severe cardiac or respiratory failure, provides gas exchange and or circulatory support. Next. The indication is for severe ARDS, as we saw during COVID, those who are unresponsive to mechanical ventilation, also for cardiogenic shock and cardiac arrest, extracorporeal oxygenator, and as bridge to transplant or recovery for short term. Next. There are different types of ECMO implantation. There's venous to arterial, basically venous to arterial provides cardiac and respiratory support. Venous to venous provides only respiratory support and can also be used in hybrid configuration. Next. There are different implantation is used depending on the patient's need. You have femoral vein to femoral artery, internal jugular vein to femoral vein, central cannulation via sternotomy, postcardiotomy, and dual lumen cannulation. Next. Here is just a picture of how some of the systems are used. Venous to venous ECMO. There's a femoral vein for drainage and jugular vein return, and the venous arterial is a femoral vein to femoral artery cannulation. Next. This is again a dual cannulation. The insertion is the internal jugular vein or left subclavian vein or right common femoral vein, and drainage is into through the SVC and IVC, which is directed into the right atrium and right ventricle. Next. Here the image, different cannulation. The venous arterial is two venous drainage cannula, and on the arterial return cannula provides both oxygenation and partial circulatory support. It's basically used when venous to venous support is insufficient and some arterial perfusion is needed. And if you look at the image B, that's venous to arterial and then arterial to venous. That's it's for balance, both cardiac support and oxygenation. The image C, which is venous arterial to venous, typically reserved for unstable cases where both strong cardiac and pulmonary assistance are required. And venous and to arterial, considered in extreme scenarios for tailored support. So it's based on patient's need. You can, if you need more venous drainage, you have double cannulation or triple cannulation. If you need more input into the arteries, then again, use more arterial support. Next.
Dr. Dubai?
Yeah.
Sorry, I just want to make a quick announcement to the audience in Nigeria. This is our last speaker, so please stay behind as Dr. Dubai will soon be finishing, and well, you got to stay behind until the very end. Thank you.
Okay, next, please. This is an AbioCor implantable replacement heart we used to use. It saved a lot of lives, but it was very costly, and due to complications, it was discontinued. Next. This is just a video of saying that those who had biventricular failure and had biventricular LVAD basically died. Next. Next. Cardiac transplant. We had a big surge from 1982, which started cardiac transplant. The first one being done by Christian Bernard in South Africa. There was a big surge in, go back please. Big surge in cardiac transplantation, as you see. In 1994, we had 4,346 transplants. And then due to organ failure and unacceptable organs, there was a reduce in cardiac transplant until in 1983 and so, when immunosuppressant drug came into the market, then there was a big surge because we had less organ failure, and of course organ acceptance was much better, and there was a big surge. The advancement in immunosuppressive medications and also AI, as well as proper pre-operative planning, has increased the operative numbers in cardiac transplant. In 2024, there were 4,182 transplants in the United States. Next. Here is the graph of, on the y-axis is survival probability, and the x-axis is the number of years. As you see, within by 15 years, at least 60% of the patients with transplant are alive, and by the time it gets to 40 years, is only less than 10%. Next. Next. Patients with, these are patients with congestive heart failure. The survival is very low without treatment. The graph on the top is for female, graph on the bottom is for male. As you see, the y-axis is probability of survival, and x-axis years since diagnosis, that you see that the length of the survival decreases, especially if untreated. Next, with the advent of cardiomems, as we discussed, which is implanted in the branches of the pulmonary artery, it's basically implantable, it's small, and can be remotely monitored by caregiver, and they can be treated before the catastrophe happens. It prevents hospitalization, improves outcome by being monitored and treated early on. Next. TMR. Go next. Transmyocardial laser revascularization has been in the market for a while. I've used it many times. It creates channels by thermal ablation, an associated inflammatory process created by enhanced thermoacoustic wave causes significant long-term angiogenic response. Next paragraph. I keep saying next paragraph. How is TMR is used? Can be as sole therapy through thoracotomy or thoracoscopically. Can be as an adjunct therapy to CABG plus TMR, and can be post-transplant and combined with gene therapy. Next. The selection is simple. Patients with severe angina refractory to medical management. The regions of myocardium demonstrating reversible ischemia, which cannot be bypassed directly and be revascularized. Unrecoverable coronary distal disease, such as diabetic and post-transplant patients, can be benefited by TMR, and left ventricular ejection fraction of greater than 25% would be beneficial in this patient. Although I had a patient who had 10% ejection fraction, he was severely overloaded, dilated ventricle. We kept him in the hospital, and he lost 50 pounds of water. Then we did the viability study, and it showed reversible ischemia. And I did 6 bypasses on him, mainly with arterial, both IMAs and radial artery, and performed 37 laser pockets, both on the right side as well as left side, in the areas that the arteries were very small, and despite the fact they were bypassed sequentially, but nevertheless they were very small. Patient was severely diabetic, and he, in 3 months, his ejection fraction went up to 35%. Next. Here, ACC and HA validates the TMR, transmyocardial surgical laser revascularization, either alone or in combination with coronary bypass surgery, is reasonable in patients with angina refractory to medical therapy who are not candidates for PCI or surgical revascularization. Next, the STS validates also the TMR, transmyocardial revascularization may be an acceptable form of therapy for selected patients as sole therapy for a subset of patients with refractory angina, and as an adjunct to coronary artery bypass grafts as a subset of patients with angina who cannot be completely revascularized surgically. So both the STS and College of Cardiology have approved this TMR, and especially is very beneficial when we do gene therapy. Next. This is the CO2 laser used. Next. This is a picture of channels created by TMR. You do multiple channels, 1 centimeter apart, as many holes that you need, depending on the number of arteries, cannot be either revascularized or very small and destined to close. This creates channels, and neogenesis starts. And definitely post next paragraph, next slide. Performing TMR. Next slide, please. These are proven clinical benefits, primary and secondary. Primary outcome, relief of angina by 2 or more classes, increased exercise tolerance. Secondary outcomes, reduction in rehospitalization, reduction in medication use, increased event-free survival, increased perfusion, increased quality of life, and long-term efficacy. Next slide. Now, next is we're addressing now gene and protein and cells. This is something that ongoing and in the future. Next slide. You have to select your the cells that you want to harvest. Next, this is like skeletal muscle. Then the skeletal myoblasts are cultured and then transported to the myocardium. Next. But the question we always ask, what type of cells we're going to use? What is the processing technique? And what are the routes of application? And then the kind of question is benefit of effects of TMR along with gene therapy application. Next paragraph. Next slide. And these are the types of cells that are being used. Embryonic cells, referred to ECS, skeletal muscle, myoblast, endothelial progenitor cells, mesenchymal stem cells, hematopoietic cells, and cardiac stem cells. Next slide. These are the studies ongoing. In the early 2000s, there was the initial experimental studies using bone marrow derived stem cells. In 2014, Mayo Clinic and Cardio 3 Bioscience was FDA approved the phase 3 trials. 2020, multiple trials have been launched worldwide using mesenchymal cells and the iPSC, which is the mesenchymal, what does it stand for? That's hematopoietic cells and gene modified stem cells. In 2023, again, BioCardia and CardioAmp used autologous therapy. They entered in FDA approval for phase 3, 2024. The help therapies used, again, the mesenchymal cells and cardiomyocytes, and it was cleared by the FDA and investigational new drugs company for first in human trial. 2025 by Cardia getting into the expected phase 3, 2026 phase 2 pivotal trial for pediatric dilated cardiomyopathy is planned to start. And at the present time, there's no FDA approval for stem cell therapy for myocardial regeneration, but research is ongoing. Next. And this is the Dusseldorf German protocol using stem cell processing. They harvest the stem cells, they culture it, and then they prepare it. Within 2 hours, it's ready. Then in the meantime, the surgery starts, either thoracotomy or minimally invasive. The grafts are harvested, the bypass are done. Then they use TMR to create channels, and then the cells are injected around each channel created by TMR. Next. This is a heart which already has had multiple channels created, as you see, and the stem cells are injected around the channels. So this is around the immediate vicinity of the laser holes. Next. This is the echocardiogram pre injection, and 3 months and 6 months after. As you see, there's significant improvement in the stage ventricular activity. Next. The preliminary results from Dusseldorf reported no processing failure, no intraoperative mortality, improvement of cardiac function, and improvement of quality of life. 2 patients died during the follow-up. Both of them were non-cardiac. One died of urosepsis, the other one as a result of ruptured abdominal aortic aneurysm. Next. Now, this is the last topic. I'm sorry that it took a little time. Video-assisted thoracoscopic surgery is becoming a milestone in lung surgery. Next. Thoracoscopic procedure was introduced about 100 years ago by Hans Christian Jacobo from Sweden. He actually performed, he was a professor of medicine, not surgery. He used a cystoscope to perform thoracoscopic surgery in a patient with tuberculosis and related pleural adhesion, and he survived. That was in 1910. In 1933, Everett Graham performed the first successful pneumonectomy. Patient had lung cancer and survived the surgery, making the milestone. 1980, thoracoscopy widely used for diagnostic procedures, biopsy, pleural disease management. In 1992, Robert McKenna performed and reported the first VATS lobectomy for lung cancer. From mid-1990s, adoption of VATS lobectomy in major thoracic centers worldwide was introduced, and in the years of 2000 now, VATS established as a minimally invasive standard for lobectomy and wedge resection. Everything that we do today, and I do, is basically via VATS. Sometimes you have to make a bigger incision for patients who have a huge lung and have to do pneumonectomy, cannot come through a little utility site. But most of the patients that we do is done through VATS. And, you know, depending on the drainage, as soon as the chest tube is out, they can go home. In the present time, the widespread adoption of robotic assisted thoracic surgery is becoming more and more popular. Next slide. This is the old technology, posterior lateral thoracotomy, as you see. Next. This is the open technique. We used to really open the chest and, of course, put our hands in. Naturally, it was faster, and you could see it in 3-dimensional. Next. This is the anatomy of the lateral chest now when we do VATS that you have to be aware of the nerves, of the arteries, and of the muscle, so you can do muscle sparing incision. Next. Incision side, this is lateral thoracotomy. Next. Posterior thoracotomy incision. Next. This is anterior thoracotomy incision. Next. And this is a lateral thoracotomy incision. Next, this is the VATS placement. You know, usually the utility side is the 4th or 5th intercostal space, and the camera goes into the 7th intercostal space in the mid-axillary line, and the posterior axillary line is for the instrument. Next. Can you run the video? This is a camera showing the lungs, and then through this, you can also use other sides, as you see on the left side, to bring down or make your utility incision and the other. So the camera is very nice and you could really see it. Now, of course, this is a nice one because there's no adhesion, and you can dissect the arteries and veins and ligate them. And if you have to do lobectomy, it makes it simple. It is more difficult when the lung is totally adhesed and stuck to the wall. So you have to take time to release the adhesion and do pleurectomy. Next. This is just the two holes and the incision sites for the utility port. Through one of these holes, you put your chest tube, and the other one actually you steri strips on. You don't have to sew it. Next. These are the regular and routine procedures done with VATS. Do lung biopsy, pleural effusion, for pleural effusion and empyema drainage, pleurodesis, pleurectomy, decortication, bulbectomy, lung biopsy, lobectomy, pneumonectomy, mediastinal mass resection, sympathectomy, and for pneumothorax management. Next. Run the video, please, on the right. For patients who undergo VATS, you do double lumen endotracheal intubation. Can you run the video, please, on the right? Double lumen intubation, because you want to drop the lung that you want to work for. Since this is the right, right chest, so you do drop the lung on the right side, put your instruments in, and then you go ahead and do your procedure. Next. The advantage of VATS is reduced postoperative pain, faster recovery, and shorter hospital stay, lower risk of wound complications, better cosmetics. The limitation is required surgical expertise. It's a limited tactile feedback and not suitable for all large or invasive tumors. Next. In conclusion, evolution and milestone from pioneering open sutures to robotic surgery, role of teamwork, innovation, and perseverance in advancing the field. As William Osler said, medicine is a science of uncertainty and an art of probability. Next. I want to thank you for staying with me for an hour, and I hope you appreciate our pioneers and what they have gone through to get us where we are. Thank you.
Thank you, Dr. Sabah.
Thank you, Dr. Harold. Thank you so much.
Thank you.
Thank you very much.
Bye-bye.
Now, that's California, and that's you on the beach. You giving a talk on the beach, looks like?
I'm not on the beach right now, but that's my IT made that happen.
Ah, okay. That's that's AI in question.
I'm in the office. I'm in the office actually, going to surgery in about 10 minutes.
Very good. Well, we will let you go very quickly. Thank you very much for the very comprehensive overview of cardiac surgery, and it's from the early pioneers to current day modern techniques, including robotic surgery, and we really appreciate giving us the time and opportunity to learn from you. We hope that the audience, which has been quite patient, if they have any questions, I'll have them say yes or no. Any questions? However, one question before you go. What is the benefit in your mind between VATS and Da Vinci directed lobectomies, if there's any possibility?
Well, you know, I invented the first robot. I can tell you, I only use it sometimes for taking down the IMA. I feel that with the advent of new devices that the industries have come out with, the long instruments, you can do the procedure much faster than using robots. We use robot, I shouldn't say this, but we use robot nowadays as a gimmick because patients are clueless of really what we do. They feel that robots doing the surgery, not realizing it's us and it takes longer. The first patient I did robotically asked me, Doc, would you be willing to undergo robotically assisted CABG? I said, no. I said, no, I wouldn't. But he said, oh, Doc, I trust you, and I want to be on the paper. I want to be in the newspaper and show it to my kids. I let you do it. The fact is, they trust you, and you have to choose the right thing for the right person. If you feel that you're going to put somebody under anesthesia for 5-6 hours, but you could do the same surgery in an hour and a half, why would you select that? Now, there are places for robots, and there are places for minimally invasive. We can make the same incision, just like you saw in the chest. I can do this with long instruments as we do, to do a procedure much faster than if I were to use a robot with 5-6 different holes, and then somebody has to change the arms with it to scissors to the bovie and blah blah. It takes a long time just to say we did it robotically. But again, we use new technologies, and as we become more and more apt to it and become more perfect and faster, it's okay to use it every so often, but it is not for everyone. My father went for surgery, and the doctor was a very nice doctor, was actually DO, and he said, I do robotic. I said, listen, I know, I've been there. If you want to try it, do it, but if you fail, don't try anything else. And well, he went, because I knew the tumor was too big, was not good for this kind of a work. He tried it. After 2 hours, he went and opened and took the tumor out. The thing is, you have to be a good surgeon to realize the limitations. You realize what is good. If you start something and you feel that it's not going to do the right thing, you stop and convert. Don't be afraid to convert from robot to open or minimally invasive, because the main person that you're dealing with is the patient's safety and outcome. If your outcome is going to be better doing it open or minimally invasive, then convert to it. It's no embarrassment. Everybody does that all the time because there's more complications with that. But if you feel comfortable and it's smooth, it's nothing difficult, you want to go all the way, then you have to use judgment. Any other question?
I think that's okay. Any other questions from the audience, from the virtual audience? Except this question from virtual audience. Otherwise, we don't have any more questions here. Yeah, thank you. I know you have to go operate, so I appreciate you giving us this exhaustive and comprehensive review, and we appreciate your time. I'll be in touch. Enjoy California while we enjoy Nigeria. Thank you so much.
Yeah, thank you. I wish I was there personally, but next time.
Next time.
I like to visit.
Next year, yeah. Thank you so much.
Thank you so much. Bye-bye.
Thank you. Thank you. Okay. Dr. Ibrahim, are you there?
Yes, I'm here.
Okay, so I think we need to wrap this up. At this point, I'd say thank you very much, the in-person audience and the virtual audience members for staying this long to see us through some technical difficulties throughout the presentation. At sometimes you all stayed cool, and I appreciate that. We would like to say again, you've seen the advent of cardiac surgery, like the last speaker talked about, from the early days to the new days, from heart failure devices to heart transplant, from things that will keep you alive now. Even if you need heart transplantation, you can walk around with an LVAD device and be okay for as a bridge to heart transplant. The heart's not just sitting there for you to have. So again, that's the technology. AI, the previous speaker before him, talking about the value of AI, incorporate AI into our daily lives as clinicians now. If you're seeing a patient and you're unsure of what's going on, you can simply ask AI, what are the indications for this? And it'll tell you. And then you can then put it with your clinical expertise and then come up with the solution and appropriate referral as need be. The main theme for the conference is well known, as peripheral arterial disease, management, and the need for us to prevent amputations. Our goal simply is making our patients aware, making our physicians and non-physicians aware, healthcare workers aware about PAD and implications of PAD when not recognize the fact that it can lead to limb loss or amputations. So if you're in a situation where you have a family member or a friend or colleague thinking that they may have a PAD-related problem, you've heard a whole day's worth of PAD-related conversation. That should steer you or steer them in a direction where they can get help. We also look forward to Thursday. If you can tune in, there'll be a different set of speakers, again, on PAD-related topics that will crystallize this for you. Again, this is supposed to be a practical endovascular conference. So if you have any questions about some of the topics we talked about, anything that boggles your mind, call me. I'll talk to you over. If you want to see demonstration down the road at some point, we'll be glad to do that for you. When patients come in, the most important thing you have to do as a nurse, as a doctor, is to ask the right questions. The history, the physical examination, put your hands in the patients, find their pulses, touch them, so that way you know what they have and what they don't have. Then lastly, in a community where we don't have all the technology at this time, we still can use minimal invasive technologies to help our patients out so they don't lose their limbs. So on behalf of the Oye Global Medical Foundation, the Edward B. Dietrich Vascular Society, the Uzuma Medical Foundation, and all the other partners, the Dialysis Specialist Hospital, the Silver Cross Healthcare Diagnosis Healthcare System, I'd like to say thank you to all of you, and we wish you a wonderful evening, and we'll look forward to seeing you on Thursday via Zoom, and for those who are in Lagos, we'll see you in person. Thank you once again. Thank you.
Yeah. Thank you, Dr. Oye.
Thank you. Thank you, Dr. Ibrahim.